My name is Veronica Ajewale. It is such a pleasure to have you join us for our program today as we discuss on prostate cancer. During the rest of this program, you would have an opportunity to hear from an amazing group of experts and panelists as we take a deeper dive into the whole concept of prostate cancer. We are also going to have panel discussion of lived experience as well as support system for individuals that have gone through treatment with prostate cancer. So write your questions, sit back and engage with us. And I want to say a big thank you to all our speakers, our panelists, vendors, the partnering institutions, and most importantly, to each and every one of you, the community members, for engaging with us on this topic. We look forward to seeing you and continuing to engage with us as we work together to advance health equity on prostate cancer. Thank you and see you around.
Good morning, everyone. Good morning, good morning. Hello. Good morning this Saturday morning. And I'm going to say good morning again. And thank you all for making it out here, leaving your busy schedules like, family time and whatnot. We really appreciate you to come here to just support our men in the community and in the world in general. Without further ado, I want to thank you all to the 4th annual face-to-face, shoulder-to-shoulder, let us talk about prostate cancer and prostate health. You are welcome again. To also those joining us online in a webinar format, you are also welcome. And I have the pleasure, without further ado, to welcome our master of the ceremony for today's occasion, and that is in the person of Miss Edith Declan, who is a family nurse practitioner, educator, and researcher whose career reflects a deep commitment to bridging the gap between science and society. With more than a decade of experience spanning primary care, nursing education, clinical research, and community engagement, she has become a trusted voice in promoting community health. She earned her Master's of Science in Nursing from the University of Texas Health Science Center at Houston, where she's currently pursuing her PhD in nursing. Bravo to you, ma'am. She also holds a bachelor's degree in nursing from Prairie View A&M University, an associate degree in applied sciences, and a licensed vocational nurse certificate from Houston Community College, step by step, precept upon precept. Additionally, she earned a bachelor's degree in mathematics and education from the University of Abuja, Nigeria. She is a clinical translational research and community engagement nurse practitioner here at TSU, and we're honored to call her a colleague and a member of our home. Thank you, Edith. Can you please give a round of applause?
Thank you. Thank you so much, Dr. Obo. All right, good morning, ladies and gentlemen. How are we doing today? Good morning. Can we turn it up a little bit? Good morning. Awesome. Good morning, everyone. My name is Edith Declan, and there is no better way to introduce myself than Dr. Obo's introduction right there. I'm humbled to be here before each and every one of you, welcoming you to the face-to-face, shoulder-to-shoulder, Let's Talk About Prostate Cancer event. Now, today, as you all know, we're not just gathered here for just another community event. This is a movement. This is a call to action. This is a call to awareness, advocacy. We're not just here because we don't have anything else to do in our houses today, but we're here to show support. We're here to love. We're here to share the word on prostate cancer and to help as many people as possible. Now, research shows that 1 in 8 men, that's a staggering number, 1 in 8 men will have prostate cancer in their entire lifetime. And then also, Black men are more likely to have prostate cancer and even more likely to die of prostate cancer. And I'm sure we all know the reason for that. Now, for too long, prostate cancer has remained a silent shadow in too many families, in too many lives, in too many homes. Nobody's talking about it. But today, we are ending that silence intentionally. Today, we're coming together as warriors. We're coming together as survivors. We're coming together as healthcare leaders. We're coming together as community champions and standing together to say we are going to face prostate cancer head on. This gathering is not just a community event. It's full of information. It's empowerment. It's about men taking charge of their health. It's about families learning how to protect and to support their loved ones. Somebody asked me earlier, are women invited to this prostate cancer event? And I said, absolutely. Think about it. Women are the reason why men go get their prostate exams after all. Okay, so some men would not take these initiatives if they don't have the support that they need to take these initiatives. Some men are not going to get screened. And think about it, if a man in your life, your husband, your son, your relative, your father, develops prostate cancer, you as a woman will be the next available person to give them all the support that they need to fight and to survive that condition. So women are very much welcome to this event. We're here to learn, we're here to share, we're here to screen, we're here to prevent, and of course to save lives. Prostate cancer can never define us. It would not define our communities. It would not define our families. We will define prostate cancer because the way we respond to it eventually will make the difference. Today we're here to raise awareness. Today we're here to honor the warriors, the survivors. We're here to take action to protect the health of those that we love. Fathers, brothers, sons, in-laws, partners, friends, relatives, as the case may be. So whether you're here in person or joining us online, I want you to know this. You are becoming some part of something really big. You are becoming a part of a community that is united for hope, united for life, and of course for healing. So, ladies and gentlemen, let us open up our hearts, sharpen our minds, and roll up our sleeves because together we are rewriting the history of prostate cancer in our communities. Now, in order not to take too much of our time anymore, we're going to go straight up to our agenda for today. We'll first of all be having our opening prayer, and then after the opening prayer, we'll have an opening remark from no one else but the director of our program, Dr. Veronica Ajewale-Wema. And then afterwards, we'll be overviewing the TSU Community Engagement Core and clinical research programs. We'll have a speaker session. And then afterwards, we'll have a healthcare provider panel discussion. And then after that, we're going to be having some improving prostate cancer health outcomes. We'll be having a performance by the TSU debate team, a panel of discussion for prostate health. We'll be honoring prostate cancer warriors, caregivers, and all those who have supported healthcare providers as well. And then we're going to be ending up with a closing remark, a closeout announcement, and a closing prayer. Ladies and gentlemen, if you are joining us online or in person, I want to seize this opportunity to welcome you all and thank you for being a part of this tremendous event today. I want to say a big thank you to all of our sponsors, our partners, and our vendors. Most importantly, every one of you here is a sponsor today. All right, but I want to say a big thank you to MD Anderson, Aetna, P20, iHeart, and of course, Texas Southern University Center for Clinical Research and Translational Science. We want to say a big thank you also to our partners, New Hope Progressive Church. Thank you so much. Please a round of applause for them for giving us this opportunity to host this event here in their venue. We also want to say a big thank you to Harris County Public Health Department. We want to say a big thank you to Precincts 1 and 4 for providing us with support and encouraging their community members to be present here. And to all of our vendors on the other side, we want to say a big thank you for being here to support this course today, and we hope that we're going to have a wonderful time. So in order not to take too much of our time again, I want to thank the pastor of New Hope Church, Reverend Lemon Atkins, for hosting this event. Thank you so much, sir. Awesome. So we're going to have a question and answer section of this program. Please, if you are on site, you have folders. If you haven't received your folders, please indicate by raising up your hands, and we'll make sure to get you a folder. There is a QR code on the folder. Please scan the QR code to learn more about our programs. If you are online, please post your questions on the Q&A box. We have 2 unaccredited CE hours for community health workers, and you must complete the evaluation to receive credit. We're streaming live on Facebook, YouTube. You can send the information to your friends and family members who might want to be a part of this. And please stay connected to us using our Facebook account, Instagram, YouTube, and all of the rest of that. Now, I'm going to be introducing Pastor Atkins for our opening prayer. In October of 1993, Reverend Atkins became the 14th pastor of Progressive New Hope Church, Baptist Church. And as a man of great vision and enthusiasm for advancing the kingdom of God, he works faithfully equipping the people of God for the work of ministry. In 2011, he led the congregation into their new state-of-the-art $1.2 million worship and ministry facility and was blessed to retire the debt in 2022. Please another round of applause for him. I don't know how many people can do that. All right. So Pastor Atkins holds a Bachelor of Science degree in Business Administration from Grambling State University in 1978 and has earned a Master of Divinity degree from Houston Graduate School of Theology in 2015. He is an active member and lecturer in the Baptist Ministers Association of Houston and vicinity, and a general treasurer of the Third Word Fellowship of Churches. He is recognized and esteemed by his colleagues and associates as one of his generation's outstanding preachers. Ladies and gentlemen, please, with a round of applause, let us welcome Reverend Lemon Atkins, please. Thank you very much, sir.
Welcome, welcome. Let us pray. Gracious and eternal God, our Father, how we give you praise and glory for another day, a day of life, a day of health and strength. And then thank you for the heart, the mind to come to this gathering that we might share in this promotion of health information to the community at large. Thank you, Father, for the visionaries who thought of this, who are empowering this program. And then thank you for our speakers and all of our attendees and our vendors and our coordinators who have gathered here today to make this conference possible. Bless us now. Empower us that we might empower others. Oh God, give us clarion voices, give us clarity, give us wisdom. Oh God, and for all your blessings upon our lives, we will in turn give you the glory. It's in Jesus' name we pray. Amen.
Thank you very much. Thank you so much. All right. So to give us our opening remark for today, we're going to be calling on Provost Carl Goodman. Dr. Goodman holds a doctoral degree in pharmacology and toxicology from the Florida A&M University and a bachelor's degree in biology and psychology from Jacksonville University. He was a postdoctoral NIH fellow at the National Institute of Drug Abuse. Prior to his appointment as provost at TSU, he served as provost and senior vice president for academic affairs at Bowie State University, BSU. Prior to joining BSU, Dr. Goodman was with Florida A&M University, where he served as associate provost for academic affairs and student services. Dr. Goodman has over 30 years of a distinguished academic career in teaching, research, and service. Additionally, Dr. Goodman has extensive experience as a researcher on grant-funded programs and is passionate about providing research opportunities for undergraduates, graduate students, and faculty. Ladies and gentlemen, please, with a round of applause, let us welcome the Provost, Carl Goodman. Thank you very much, sir.
Thank you. Good morning, everyone. How are you all doing this morning? First and foremost, I want to say thank you very much for Pastor Atkins for at least allowing us to be in your house. Here at Texas Southern University, I want to definitely give greetings and welcome on behalf of our 9,000 students, our 14th president, Vice Admiral James Crawford III, as well as our faculty, staff, as well as I mentioned earlier, our students. Today is definitely a special day when I look at it. As mentioned in my bio, serving as the provost of this great institution, Texas Southern University, there are a lot of amazing things going on, but I kind of pride myself on really my commitment to research. And research really, particularly in terms of myself, in the Black community. And so today's is a special event to me because really when you talk about prostate cancer prostate cancer really is a major effect really on minorities, particularly black and men of color. As was mentioned earlier, definitely having females, our wives, our loved ones out here, really getting men more involved in terms of their prostate and screening is probably one of the most important pieces that's out here. We just don't know how important really it is, early diagnosis of prostate cancer, what it means. As far as black men are concerned, we are twice as likely to be susceptible to prostate cancer, and even more so be more aggressive type of prostate cancer affecting black men. And so when you talk about prostate cancer, it's not just about data. You're talking about, fathers, grandfathers, uncles, brothers, neighbors. And this is the reason why today's event is so special and so important. I really want to thank, again, my team, particularly look at TSU. TSU holds a great history in terms of education and really social justice. But today, we're really talking about healthcare and community service. And that's one of the great things we have here in terms of Texas Southern University, really, in terms of how we are giving back to the Third Ward, giving back to Houston, giving back to regionally and nationally and globally. And so I want to thank everyone for being here. And if there's anything that I can personally do to really help and to continue to promote prostate cancer and really in terms of the screening and diagnosis of prostate cancer, please let me know. And definitely I want to thank my team who's here really as part of this and wish you all a great conference today.
Thank you so much, Dr. Goodman. Next, I'm going to be calling up the brain behind today's event. Dr. Ajewole, let me start from the beginning. Her name is Veronica. I want you to say Veronica, okay? Awesome, all right. So, Dr. Veronica Ajewole serves as a professor of pharmacy practice and assistant vice president for clinical translational research and community engagement at Texas Southern University. She is a clinical pharmacist and an adjunct assistant professor of oncology at Houston Methodist Hospital. She received her PharmD from Texas Southern University and completed her oncology pharmacy residency at Houston Methodist Hospital. She is a board-certified oncology pharmacist with clinical practice in oral chemotherapy at Houston Methodist Hospital Cancer Center. She is the founding director of the NIH-funded Community Engagement Core of Texas Southern University's Center for Biomedical and Health Research and TSU's Institute for Health Empowerment, Advancement, Research, and Training. Dr. Veronica Ajewole is the convener of this conference. We're excited to have her present on health empowerment programs at TSU. Please join me as we welcome Dr. Veronica Ajewole. Thank you very much.
Thank you so much, Edith. Thank you, and good morning to everyone. It is a pleasure to be here. You know, every time I sit and they are reading this bio, I'm like, God, to you and to you alone be all the praise. Because everything that you see on there, it's none of me. I am nothing but a yielded vessel. And I give God all the glory. Thank you all for joining us this morning. It is such a pleasure to see all your faces, and especially for the ladies in the house. Please help me to appreciate the women that are sitting in this room today, and for everyone that is joining us online. Provost, we are very grateful for your leadership and your support. Thank you very much, Provost. Thank you, Dr. Esther Olaleye, and to the entire leadership of Texas Southern University. We are very grateful. Let me make sure I have my slide advancer, please. Thank you so much. So my job here is very quick. I would not stand in between us and the main focus of today's event, but I will be going over the programs that we have here at Texas Southern University, just to again further inform us of all the capacity that Texas Southern University has regarding health advancement. In 2020, we had the privilege of receiving funding from NIH to establish the Center for Biomedical and Health Research under the leadership of Dr. Esther Olaleye. Sorry, she recently changed her name, and I am still trying to, make sure I say it correctly. Dr. Esther Olaleye and several leaders that you see on the screen, and it is under that mechanism that Texas Southern University has really been empowered to implement the Community Engagement Core. Over this time frame, we have had the privilege to network with several community-based individuals, faith-based organizations, clinics, and community people just like each of you sitting in this room this morning. And I am beyond proud and excited to share that during this, 4 or 5 years time frame, what you see on the screen is the best way that I can summarize the extent of our impact and success. We have touched and reached over 5,500 individuals within our local community. Thank you. And, we could not have done that by ourselves. It takes intentional collaboration. And I am just very grateful for everyone that has supported us, everyone picking up the flyer, people texting, Veronica, okay, this is what I will do, people buying the food, the water, and everything else to make sure that all our programs and events are successful. Not only that, in all the works that we have the privilege to lead, we have summarized it under IAT because Texas Southern University is still an academic institution, right? And in us being an academic institution, we have that commitment to train the next generation. So not only are we doing health-related work, community service, but we are deeply committed to training the future generation. And I am a TSU alum. I graduated 10 years ago. Exactly 10 years ago, May 2015, I graduated from TSU. So I am a product of the training, and there's just nothing else that is as fulfilling than having that opportunity to give back. And there are people in this room this morning, 2 people that were in my interview as a student, Dr. Laleye and Dr. Onta. Both of them interviewed me to get into pharmacy school at Texas Southern University. So my commitment to giving back to TSU and to the community goes deep, wide, and deeply rooted. And we are just grateful to be able to do this alongside each of you. This morning, why are we here? We could be grocery shopping. We could be, watching some movies or, just having some good times with our family. But the graph that I'm showing you this morning tells us the reason and the importance for us to gather and have such a meaningful conversation around this topic of prostate cancer. Provost Goodman was right on point. Prostate cancer does not just impact a man, it impacts the entire family. Fatherlessness in our community is not just because of incarceration, accident, drug addiction, or what have you. Prostate cancer claims too many lives. And we have to do it differently. We have to stand strong to advocate for ourselves, for our loved ones, and our families. You see all the racial representation there. And if you pay attention to the light blue bar, that is men of African descent. I want to stand tall, right? In the midst of your colleagues, right? You want to stand tall, but not on a graph like this. This is not where we should be. So we are here again this morning to have a conversation that will continue to empower us to not just be aware, but also to take action. As of last night, almost 49 individuals have pre-registered to receive no-cost PSA screening this morning. So that tells us that the fruit of the seed that we've been sowing is definitely yielding results. And we will continue to see that fruit yielding results in the right direction. When we had this question come up, we received our first grant around prostate cancer in 2020 alongside Dr. Grace Loud and Dr. Uche Ndefo. We did that in collaboration with Houston Methodist Hospital, Sankofa Research Institute, several community advisory board members, some of who I see in the audience this morning. Yes, they are right there, that supported us since 2020, as well as our pharmacy interns. And in that program, we decided that no, we will not keep quiet, and we were able to establish TSU Prostate Cancer Screening and Prevention Center. Even though that funding came to an end in 2022, our commitment to health advancement did not stop. We have been very blessed and privileged to receive additional funding from NIH and the National Cancer Institute, $2.4 million award that Texas Southern University was the only institution that was funded in 2023 cycle. That again tells us that we continue to stand out. Yesterday, late last night, I received the email from the Office of Research that this funding was again renewed around 5:30 p.m. Right? So only God could do that, and we are just incredibly grateful. Not only do we continue to expand our capacity in research and student training, we have also successfully implemented a clinical research program, the very first of its kind here at Texas Southern University. What does this mean? This means that TSU has become a clinical trial site. And with that, we have established a clinical research registry. As of last week, we've had over 140 individuals over the past 3 months that have indicated interest in participating in clinical research. We are very grateful for this. Not only that now, TSU mobile units. Those that have been following us for some time, you will see that I have, shared about TSU mobile units. And TSU mobile units is now here in Houston. It's no longer a sketch. It's no longer something in my mind. Now it is here live in Houston, Texas. It is in a storage, and we continue to trust God for divine alignment that these mobile units will begin to provide clinical services to the community in a matter of few weeks or months from now. Now, I will be remiss if I don't take a moment to pause and appreciate the amazing team who support the implementation of all these great works. Please, TSU team members that I have the privilege to work with, please stand up and for recognition, please. Cassie, Lauren, you all, please. Several of them are over there. Several of them are, in the front desk. I truly, truly appreciate you. Thank you all for all your hard work and your dedication. You may please be seated. There are faces, however, that you don't see on this screen, and that person is my husband. Please help me to appreciate my husband. I am very grateful. Thank you. When it comes to envisioning, there is the pain that comes with it. This is the man that tells me, Veronica, God called you here for a purpose. It helped me to realign with my purpose, and I'm very grateful for that. Thank you. Also, we have our 2 older kids, Daniel and Joshua. They are sitting back there supporting us as volunteers this morning. Thank you guys so much. We love you. Lastly, I want to say thank you again to all our sponsors, partners, and vendors. We could not have done this without you guys, and we are just grateful. For our speakers and panelists, thank you for sharing your expertise with us this morning, and I will turn it back to Edith. Thank you.
Thank you so much. Thank you, Dr. Ajewole Wema, for that. As you all can see, everything that we're doing here at TSU is intertwined. The community engagement, the clinical research, prostate cancer health and prevention, and a host of other things we do all connect together. We're not only reaching the community by educating them, we're encouraging participation in clinical trials because research shows that people of color are not participating in clinical research, and that is not helping the drug development process. Because guess what happens? If you're not part of the process, how can the outcome be beneficial to you? So everything we're doing here today, by the grace of God, is geared towards a healthier community that will serve you, serve your children, and serve all of our generations unborn. So to proceed, I'm going to be introducing Dr. Curtis Pettaway from MD Anderson Cancer Center. Dr. Pettaway is a professor of urology at the University of Texas MD Anderson Cancer Center in Houston, Texas. His clinical practice is based on treating patients with genitourinary malignancies, which that's a big one, but I'm gonna try to break it down. Okay, so it means the genital and the urinary system, right? So when you combine the genital and the urinary system, you get genitourinary, right? Malignancies means cancer, any kind of tumor that travels, okay? Sorry. All right, so including penile, urethral, and prostate malignancies. Dr. Pettaway has also served as the co-director of a National Cancer Institute-funded study evaluating the influence of West African ancestry on the incidence and aggressiveness of prostate cancer among African American and Puerto Rican populations. And when Dr. Provost spoke earlier, he mentioned that African American men, unfortunately, are more at risk for the aggressive forms of prostate cancer. And sometimes we might wonder why, but of course we know that the lack of access to educational materials, resources, even at the time of diagnosis, support systems. When you remember that you don't have anybody at home to support you through this diagnosis, the impact is even more, it's how do I put it? The impact is felt more. So, but if you have support, you know you can go home and discuss with family members, you find out that you are at least a step towards recovery. So please, ladies and gentlemen, join me this morning as we welcome Dr. Curtis Pettaway to the podium. Thank you very much, sir.
Hi. How's everybody doing? Let's see, we got that. Yeah, that's up there. Okay, good. All right. So how's everybody doing this morning? Glad to see everybody. I must say that, that Dr. Azuoli, Veronica, she is a very powerful force. And, she's the kind of person that when she calls, you just say, what do you need me to do? It's one of those things. And I've enjoyed immensely working with her and the TSU team. I think I've been here maybe 3 times before and will always be happy to participate in anything you're doing. The reason I like Veronica is that she's very intentional. Whatever she sets her mind to do, she's going to do it. And I really enjoy working with her, very dedicated, has a heart and a passion for everything she does. And, she's brought so much knowledge to me about what TSU is doing. And I look forward to continuing our partnership over the years with respect to actually trying to formalize that and get grant funding together. We started it and we haven't finished it yet, but we're going to get there. So today I'm going to talk to you a little bit about prostate cancer. Start off with a little bit about prostate health. What is the prostate? So it's this organ that sits underneath of the bladder, in front of the pubic bone. What does the prostate do? It produces proteins that liquefy semen. So it's important for men in the reproductive years, okay? After that, its function is not so important and one can do without the prostate. How do you examine the prostate? Well, we stick a gloved finger in the rectum because it sits right in front of the rectum, right there. Whoops, I went the wrong way. I'm going to be challenged with this today, I can tell. Okay, all right. So, sits right in front of the rectum, right there. And The other way we can examine the prostate is by imaging, either ultrasound or MRI. So what are symptoms related to the prostate? So the prostate sits beneath the bladder in front of the rectum, and the prostate can serve kind of as an impediment when it gets large to urine flow. So what kind of symptoms might you expect? Decreased force of stream. When that urine sits in the bladder, it can become overgrown with bacteria, so you can develop an infection, burning, fever. As that urine irritates the bladder, you can have frequent urination, pain, discomfort, things like that. So three processes affect the prostate: inflammation, hyperplasia, and carcinoma. Inflammation is just the prostate basically becomes inflamed either due to bacterial or non-bacterial causes. Bacterial infections can be treated by antibiotics. Hyperplasia is growth of the central portion of the prostate, and it occurs with age. It's one of the most common things that occurs in men over the age of 50. And when hyperplasia occurs, you can have any of those symptoms that we talked about before. Today, we're going to focus on prostate cancer, which is kind of the unrestrained growth of prostate cancer cells such that they lose contact inhibition. They can then invade through the capsule of the prostate and then spread to places like regional lymph nodes or bone. So today, we'll talk about the incidence and mortality of prostate cancer. You've heard this. I'm going to reinforce it for you. The important need for early detection of the disease as a strategy to decrease mortality. We'll talk about some of the clinical trial data that talks about the benefits, and there are some harms of detection, which we'll talk about. We'll talk about strategies that we've now developed and implemented to reduce those harms of detecting prostate cancer. And we'll talk about guideline now recommendations for Black men. So data you've heard about already. Second most common cause of cancer among males, certainly over the age of 50, and the second most common cause of cancer death. So this year it's anticipated about 300,000 men will be diagnosed with prostate cancer, and about 35,000 will die of prostate cancer. The lifetime risk is 1 in 8 for the general population and higher for Black men. Now, when you think about 35,000 men dying of prostate cancer this year, that means during any 1 hour, 4 men somewhere in this country are going to be dying from prostate cancer, okay? So that brings it kind of down to home. And prostate cancer is very, very common. It's estimated that over 3 million men are living with prostate cancer right now. So when we look at the numbers with respect to risk factors, we know that race and ethnicity certainly is a risk factor. And Black men are about 67% more likely to get the disease. And as you've heard already, over twice likely to die from the disease, even in contemporary times. The other risk factors that we talk about are age, and this shows us the interplay between age and racial group. So if you look at the curve on the left side, Black men are depicted in that purple line, and what you can see among all men, prostate cancer becomes more common as you get older. You can see the curves go up. You can see that Black men have that highest curve up there in the purple. But what you also see is that the disease starts about 5 years earlier for Black men compared to the other racial and ethnic groups. You see something similar for mortality. Again, more men die as they become older. And what you see is that death from prostate cancer occurs earlier for Black men. So what are the components of this mortality? Why do Black men die of prostate cancer more frequently? It is not related to only one thing. There are multiple things that are related to this. A very common thing, though, that you all can appreciate is not having access to the healthcare system. But beyond that, there are patient biases, physician biases, and even institutional biases that occur that Black men are treated differently than other populations. They're less likely to have surgery. They're less likely to have cutting-edge diagnostic tests. So the health care they get in some instances is inferior. Another thing that we found over time is that the biology of prostate cancer among Black men can be more aggressive. If we've looked at what research has shown us, and I'll just kind of summarize some of the literature here, we know that the disease onset is earlier. We and others have done studies that showed even in earlier disease, the volume of prostate cancer among early diagnosed Black men can be higher. Historically, maybe not so right now, but Black men presented with prostate cancer that had already spread at the time of diagnosis. And we look at the molecular profile of prostate cancer among Black men, there are notable differences between white populations. So all of these factors come together to tell us that early detection of the disease is certainly one strategy that we can use to diagnose the disease earlier. So when we look at other risk factors, what are some other risk factors? Well, prostate cancer certainly can occur in families, and we know that family history is a risk factor for prostate cancer. Now, if we look at the definition, it's members of a family with prostate cancer in 3 successive generations, like a grandfather, father, and a son, or 3 affected first-degree relatives, a father, 2 sons, or 2 first-degree relatives with a diagnosis before the age of 55, that early onset of disease. And if you look at its effect on prostate cancer incidence, you can see it on this slide. That first curve with the dotted line is one of showing the population risk of prostate cancer overall. So that's the lowest one. Now, the next one up is if you have one brother with prostate cancer, your risk goes up by 2-fold. If you have a brother and a father, your risk goes up by about 5-fold, okay? So that's telling you almost like a gene dose effect. So this is telling you that there are things that potentially can be transmitted in families that increase your risk of prostate cancer or potentially even aggressive disease. And what are some of those things? Well, we know that cancer is a genetic problem, right? And prostate cancer is one of those cancers that has one of the highest risks of genetic transmission. We now know that the number of genetic loci on chromosomes is huge for prostate cancer, over 400 genetic loci. And you can basically break them down into what we call the weak genes or the strong genes. The weak genes are what we call lower penetrance loci, that just because you have that one loci doesn't mean you're going to get prostate cancer. But the more you have, the higher the likelihood. And you might see things like genetic risk score or polygenic risk score. These are now ways to basically stratify your risk of prostate cancer or getting prostate cancer in the future. These tests are starting to become more and more available. Now, they're not as clinically significant as these higher penetrance loci or, quote, the strong genes. These are not very common in the population, but if you have one of these, it's very likely that you are going to get the disease and you might get an aggressive form of the disease. We've heard about some of these in heritable prostate cancer syndromes, like breast ovarian prostate cancer syndrome, where we know about the BRCA1 and 2 genes. We've heard about these in breast cancer and ovarian cancer. Well, they also predispose to prostate cancer. If you have a BRCA2 mutation, you're 2 to 8-fold more likely to get the disease. It's likely to be high grade. You're more likely to have metastatic disease or even die from the disease. The Lynch syndrome genes, which are important for hereditary colon cancer, also increase your risk for prostate cancer. And then there's another gene called HOXB13, which is prostate specific, and it predisposes to the early onset of prostate cancer. And there's actually one specifically for African American men now. Now, how do we diagnose prostate cancer? The most common way nowadays is by the PSA blood test, which is available for you out there from Harris County Health, which is great. So this is a protein produced by prostate cells that is specific for prostate cells, but not specific for prostate cancer. So historically, a PSA below the 4 threshold was felt to be, quote, a normal PSA. That is not necessarily the case, and it's important to know what your baseline PSA is and what your trends are doing over time. There are many men who have PSA above 4 for many reasons, and it's not cancer. So that's one of the things we're going to talk about in the coming slides. What about the rectal exam? So the rectal exam was historically used to diagnose prostate cancer early, but we know it's not really an early detection test because many cancers are not even palpable because they're so small, or they could be in the anterior part of the prostate where you really can't even feel them. Now, rectal exam does become more important when you already know that the PSA is elevated. So today, the first line testing for prostate cancer is the PSA. Now, if you have an abnormal rectal PSA, then get the rectal exam. So don't be afraid to get your PSA tested. You don't necessarily have to have a rectal exam, though, okay? Now, how do we actually diagnose it? We got to get tissue. And the way we get tissue is basically by sticking a needle in the prostate. And we do that either under ultrasound guidance. Nowadays, we're doing MRI fusion guided biopsy. So the MRI allows us to image the prostate in a much more sensitive fashion than ultrasound alone. What have the screening studies shown us? This is probably one of the ones with the longest follow-up. The question is, if you take men who were not screened and compare them to men who are screened, do you diagnose more cancer and do you save lives? That's the question. So this is one of the studies that was done in Sweden where they invited 10,000 men to participate in screening, and the control group was just followed. They didn't get screened. They tested every 2 years, and if you had an elevated PSA over 3, you got a biopsy. The control group, no screening was offered. And they stopped screening at the age of 69. And so if you look at men who were screened in the red, you see that there were more cancers diagnosed. Well, you would expect that because they had more testing. But what you saw was that mortality was decreased in the men who got screened, about a 29% relative reduction. And factors that were associated with prostate cancer death were not being screened, or men who were screened, but then when the program stopped, they were not screened anymore. When you follow those men, they began to die from prostate cancer later on. So, is prostate cancer screening effective in black men? That's what we really need to know, right? This is the problem. Many of these studies, mostly all of them, did not include significant numbers of black men. So we don't know the specific answer to that question, but we can certainly infer it. When we look at national data on prostate cancer mortality in the PSA era, we can clearly see that mortality from prostate cancer has been decreasing over time, and actually decreased more in black men than in other populations. Recent trends, though, are disturbing because that rate of decrease in mortality is now beginning to level off. And we'll talk a little bit more about that. The benefits. We see now that most men are diagnosed with localized stage of prostate cancer, and the survivals are quite high. Who dies from prostate cancer? Men with distant disease, where it is still practically incurable. And that's the benefit of screening. You're not diagnosing men with distant disease. What are some harms of screening? Okay, let's talk about that. We talked about the fact that PSA is not perfect, and that many men who have an elevated PSA have an elevated PSA for many benign reasons, just benign growth of the prostate. But that is a trigger for an evaluation. That evaluation may likely mean that you're going to have a prostate biopsy. You could have a complication from the biopsy. You could have anxiety, things like that. The other thing that can happen, though, is that many screen-detected cancers tend to be low grade and low stage. That's a good thing if you don't treat them. Now, low grade, low stage prostate cancer. We know that many of these men may die of something else. So the prostate cancer wouldn't kill them, but the treatment causes complications. So you're treating something that may not have caused a problem, right? And the treatment may be worse than the disease. So what you want to do is not find these low-grade cancers. We know that there are complications of treatment: erectile dysfunction, urinary incontinence, bowel, bladder problems, and a small percentage of men may die because of the treatment. So back in 2012, the Preventive Services Task Force looked at this early data before the long-term studies came out, and they said, wow, you're diagnosing a lot of low-grade cancers that may not need treatment. You're treating them, and it's causing complications. We don't want you to do that. So they made a recommendation against prostate cancer screening, blanket recommendation. What happened? Well, we saw in the data that the use of PSA testing plummeted. What was the consequence of that? Well, you see in the SEER data, during that time, prostate cancer incidence went down dramatically because you're not doing PSA testing. But at the same time, and in the years after that, the incidence of distant disease went up. And so we've now become very, very astute to this, and we now know that you can't throw the baby out with the bathwater, okay? And this has been especially troubling among the black population. You can see where these curves with respect to prostate cancer mortality are leveling off for black men and white men, and actually starting to take an uptick in black men. So this is why early detection is extremely important. So our challenge now with respect to physicians who evaluate patients with prostate cancer are to find those clinically significant cancers, the ones that would cause you to die. We want to limit the morbidity of the falsely elevated PSA tests. And we want to limit treatment-related morbidity for the low-grade cancers. So how are we doing that? A variety of things have occurred over the years since 2011. We're now doing a lot of biomarkers. So that means that just because your PSA is elevated doesn't mean you get a biopsy now. You may get a biomarker that will talk about the risk of having clinically significant prostate cancer. You'll probably get an MRI as well. So everybody that has an elevated PSA doesn't necessarily get a biopsy now, which is basically decreasing morbidity. We have a lot of biomarkers. They're either blood-based or urine-based, and it can be very helpful. MRI is really important because it really helps us image the prostate, and it also helps us target the area of abnormality so we're really sure that we're hitting the area that we need to hit. And this is just an example here of an MRI fusion-guided biopsy, where here is the target, and you see the biopsy cores hitting that green target there. So the MRI helps us find high-grade cancers and really tends to avoid low-grade cancer detection. The other thing we're doing is for these low-grade cancers, it's not automatically treatment anymore. 60% of people with low-grade cancer now are treated with or managed with active surveillance, meaning we're carefully following you. We're going to get MRI. We're going to repeat PSA. We're going to determine if this cancer is growing or is going to become a problem for you. We found that amongst different populations, active surveillance can be very effective. For Caucasian men, about 50% may avoid treatment at 10 years. For black men, it was about 40% in one study. We may be able to expand this to slightly higher grade cancers, but among black patients, not quite sure about that yet. Now, it's important to follow patients on active surveillance because it's a contract between the patient and the physician, because cancer can grow in certain incidences. That's why it's important to have availability of these biomarkers and MRI, especially among the black population, which is at risk for aggressive disease. What do our guidelines say about early detection? The starting point should be informed decision-making. In other words, a physician or other healthcare provider talking to them about the risks and the benefits and then helping them make that decision. 6 of the 8 guidelines actually say that, but the guidelines have been confusing to primary care providers who order the vast majority of PSA tests because they vary at what age to start, what age to stop, what should be the trigger PSA for intervention, the frequency, and very few, only 2 or 3, talk about high-risk populations. So for this reason, the Prostate Cancer Foundation a couple of years ago convened a multidisciplinary panel. And basically what happened is, since we didn't have data from the randomized trials, we had to use the best available data out there. And we did a comprehensive literature review. And what we wanted to do was answer 6 practical questions about the utility of prostate cancer screening in Black men and develop practical guidelines which could be used by primary care providers to basically inform men about prostate cancer testing. So the questions were very simple, like, should a Black man be screened for prostate cancer? Well, the evidence showed that yes, the risk-benefit ratio does favor screening for Black men. What age should Black men start screening at? Because of their earlier onset, potential aggressive biology, somewhere between 40 and 45. If you have a family history and genetic risk, how does that affect it? Probably should start earlier, around the age of 40. So again, you get the flavor, practical guidelines that everyday physicians can use to counsel their patients about prostate cancer testing. Now, I also want to highlight the fact that we're beginning to really test the efficacy of these guidelines. And Matt Smith is one of our panel members here. He's one of our oncology fellows at MD Anderson. He's kind of taken the bull by the horns and asked this question right in the Houston community. So the goal of Matt's study was to assess the effect of Prostate Cancer Foundation screening guidelines in Black men to understand about their intention to screen in faith-based communities. So the first aim of his study is to determine the barriers of prostate cancer screening. So what Matt did is he basically held several focus groups in the community to find out what Black men are saying. What's their knowledge? What is their attitudes about prostate cancer? What are their perceptions? What are potential barriers to prostate cancer screening? The other thing he wanted to do was get their input on best strategies for educating. We're planning to use a video-based strategy, and we took one of my old prostate cancer videos, had them look at that, and they've modified it significantly. They said, we want this to be done in a community environment. And so actually, Matt's video is going to be done using a barbershop format. And I'm proud to say that Matt just completed the video this week, so we're looking forward to that. And the other thing he's going to do is then test this intervention in a pilot program in Houston area churches. So, Matt, we're very proud of what you're doing. So, just to close, prostate cancer is the second leading cause of death among men. And I really want to highlight that this is men of African descent, West African ancestry, okay? We see this same thing among men in Africa. We see the same thing among men in the Caribbean. We see the same thing among men of African descent in South America. So it's very common. This is the same ancestral pool, okay? There's evidence that PSA screening reduces the incidence of distant disease and death. There's also evidence for some harms. But fortunately, we've learned how to overcome some of those harms by the strategies we've talked about not immediately doing a biopsy, about when somebody has a low-grade cancer, we're not immediately running to treatment. We have new technology that's really helping us hone the practice of early detection. We're using shared decision-making strategies, and we're trying to figure out the best strategy to do this among a high-risk population like Black men. And hats off to Matt, hats off to Veronica for her efforts. We're hoping to partner with her more in the future. And we also now have practical guidelines to use. So with that, I'm going to close. Thank you.
Thank you so much for that very informative session over there. We really appreciate you. Thank you. One thing that I really got from what you said was we are enabling our patients to make informed decision, right? But how can you make informed decision if you lack information? So that is the essence of this program today. A lot of us, he had talked about genetics, the role that genetics plays in prostate cancer, but I doubt that some of us actually know what killed our fathers or our uncles or our grandfathers. So that's the more reason we should take this very seriously. We have to be very intentional about our health. We have to be very intentional about making sure that we are not part of this statistics that we talked about earlier. Thank you very much, Doctor. So next, I'm going to be welcoming Dr. Rodney Hunter. Dr. Hunter is a professor at Texas Southern University and the director of clinical pharmacy services at Memorial Hermann Texas Medical Center. He is the program director of the T.L. Burks Breast Cancer Outreach Center and serves as an advisory board member for the Texas Southern University Breast Cancer Screening and Prevention Center. His clinical interests include breast cancer, pharmacogenomics, and community health, including prostate cancer. He obtained his Doctor of Pharmacy degree from Texas Southern University in 2007. He then went on to complete an oncology fellowship at the University of Texas MD Anderson Cancer Center and is now a board certified oncology pharmacist. Dr. Hunter is going to be moderating our next session, which will be a panel of discussion. And I will be calling up on our panelists. Please, if I mention your name, please step up to the stage. The first panelist will be Dr. Matthew Smith. Dr. Smith Jr. is a board-certified urologist and urologic oncology fellow at MD Anderson Cancer Center, specializing in prostate cancer. His work focuses on community-based outreach and education, beginning with faith-based initiatives to improve awareness and access to prostate cancer screening. Dr. Smith combines his clinical expertise with a public health approach to develop community-relevant strategies to advance access to care. His long-term goal is to expand these efforts beyond faith-based community and build sustainable models for prostate cancer prevention and treatment. Please, ladies and gentlemen, let us put our hands together for Dr. Smith. The next member of the panel of discussion will be Dr. Curtis Petaway. We just heard from him a minute ago. Dr. Petaway is a professor of urology at the University of Texas MD Anderson Cancer Center in Houston, Texas. His clinical practice is based on treating patients with genitourinary malignancies, including penile, urethral, and prostate malignancies. Dr. Petaway has also served as a co-director of a National Cancer Institute-funded study evaluating the influence of West African ancestry on the incidence and aggressiveness of prostate cancer among African Americans and Puerto Rican populations. Please, let's put our hands together for Dr. Petaway. Next, I will be inviting to the stage Dr. Thomas Commander. He will be a panelist today, and he's from Michael E. DeBakey VA Medical Center. Dr. Thomas Commander is a family medicine doctor affiliated with Michael E. DeBakey VA Medical Center since 2002. He received his medical degree from the University of Nairobi, Kenya in 1990 and completed a master's in public health at UT Houston School of Public Health in 1998. He completed his residency at UTMB Galveston, Texas in 2002. He has been in primary care practice for over 20 years. He's a board medical director at Care for a Child Heart, an NGO dedicated to helping children born with congenital heart conditions get life-saving surgeries in East Africa. Thank you so much for joining us, Dr. Commander. So I am going to be passing the mic over to Dr. Hunter, and he will be leading the panel discussion session. Thank you very much.
All right, how do I sound now? Excellent, excellent, excellent. Thank you, Edith. Thank you for the introduction. Dr. Petaway, Dr. Smith, Dr. Comenda, welcome to the stage. I'm excited today for us to have this very important talk. I know I've been here for several years, and every year it gets better and better, and I'm more and more proud of Veronica each time that I witness what we're doing here at Texas Southern University. So I'm just proud to be a part of this today. So I won't belabor the fact. I think we need to get into some questions. sirs, and I think we need to really dispel maybe some myths that individuals might have about prostate cancer and how we can better attack this disease state specifically that's affecting us as African American men. So I'll start with you, Dr. Smith, and really looking at urologic cancers. Edith, that kind of, when she did the introduction for Dr. Pettaway, she was getting into it a little bit about what specifically goes on with genital urinary cancers and how they are different and how they work. So I'd like you to maybe explain to the audience about, prostate cancer specifically, but other cancers that actually affect the urologic system.
Yeah, absolutely. As mentioned before, the urologic cancers in the genital urinary system includes the kidneys. There's a tube that goes from the kidney down to the bladder called the ureter. There's the bladder itself, and then below the bladder is the prostate, and then there's also the penis and the testicles. So that's the urologic system. Within that, we talked about prostate cancer being the number one most common cancer for Black men. But also in the top 10, there's kidney cancer, which is the fourth most common cancer in Black men. And there's bladder cancer, which is the seventh most common cancer in Black men. So 3 of the top 10 cancers that Black men face are in the urologic system. Second being lung, and then third being colon cancer. So the urologic system is very important to Black men, and getting screened for especially prostate cancer, but in general being screened for cancers and going to your primary care provider can help introduce you and prevent a lot of different cancers, and may allow you to be introduced to a urologist if you need one earlier rather than later.
Thank you so much, Dr. Smith. And I think that, anybody who follows sports, you may have noticed that Deion Sanders recently was diagnosed with cancer, and it actually affected his urologic system, specifically bladder cancer. So, there's things that we definitely lean heavy on in reference to prostate cancer today. But as Dr. Smith tells you, there's other cancers that we also need to be mindful of when it comes to the urologic system as African American men. I'm going to move to Dr. Pettaway, and really talking about, you touched on it in your presentation because you touched on how important it is to identify family history, but you also had some things about genetics and genomics. So I'd like you to maybe differentiate a little bit in more detail about that in your time allotted here.
So prostate cancer and other cancers can run in the family. Because you see cancer in certain family members does not necessarily mean that it is genetic in nature. It may be that they have the same exposure. But what differentiates cancers with a genetic basis, kind of genes on chromosomes, is that the more family members you have, the higher the risk, and typically the earlier the onset. So most cancer, certainly cancer is a genetic disease. Prostate cancer is one of the most common cancers that exhibits genetic transmission. And I talked about some of those things in the talk. Other things that are important to know that actually help you and help us is that there are one, genes that will predispose you to develop prostate cancer, but also with those same genes, we can understand more about the profile of the cancer and use that to our benefit now. We know that certain proteins produced by prostate can be exploited to treat the cancer. One of the proteins, PSMA, has become very, very important. We now can target this, and it can actually be used to detect cancers that have spread to different parts of your body in a more sensitive way than we ever could before. That's called a PSMA PET scan. That same molecule can also be used to target the prostate cancer. So if you hook a lethal particle, a radiation particle, onto the PSA and you deliver it to patients with prostate cancer, you can actually improve their survivals. And one of those drugs is called lutetium or Pluvicto. So genetics, molecular biology, basic research really changing the landscape in the field of prostate cancer.
Thank you, Dr. Petaway. Yeah, we're using Pluvicto actually at Memorial Hermann as well. So it's something that's kind of started to come on the scene. It's something commonly being used. And I think Edith had mentioned about family history and how you actually obtain that. So I actually wanted to shift to Dr. Commenda. And what are some strategies and tips maybe you give patients for them to accurately obtain this family history that we really need to stratify their risk for prostate cancer?
In my clinical experience, one of the central pillars of or the ability to deploy and get patient information is when the patients gain trust of you as a primary care provider. Most of the patients who come to me, when they come to me with their wives or their spouses, I've found that it actually makes it easier for a discussion about prostate cancer. A few of the younger ones, especially the few younger ones who look like me, it becomes actually easier. And part of it, I must say, maybe because of the TikTok and social network that they have been able to find information about it. In fact, sometimes they come, they talk to me about it. But in my life as a primary care provider, when I engage my patients in discussions about cancer, I do the global picture, the global view. We go through all the cancers. I just don't limit myself to prostate cancer. We have to talk about colon cancer. We have to talk about the lung cancer. And then we talk about mitigating them, especially using the smoking cessation strategies, because we know the nicotine association with all the cancers. And then we talk about the relationship with age. If you are old enough, you are old enough to be screened for prostate cancer, colon cancer, lung cancer. If you smoke, you're going to be screened for lung cancer. Then we pivot to prostate cancer. And if you look like me, then we say people who look like you and me tend to have this prostate cancer at a very early age. So if we are 50 and above, you're already 10 years old, late if you have not had your baseline screening. The biggest challenge I've had in my practice is that many of the patients consider a PSA screening synonymous with a digital rectal exam evaluation, which is completely different. So sometimes it takes a long time for my patients to understand that there's a difference between the PSA screening, which is a blood work drawn any time of the day, and a digital rectal examination, which is different. So I do appreciate the issue of shared decision making. But like everyone understands, you can only share what you understand, or you can only share what you know. So if you have a bias of your knowledge, or if you have suspicion of this test, I have a good large number of my patients who are very extremely suspicious of lab work. They are so suspicious that they don't even want to believe any lab work. But then it takes time to engage them, to convince them, without confusing them about the role of lab work in fostering their care. So I do understand and appreciate the challenges of extracting this information. But I think spouses who are willing to take the day off and join their spouses to go to see the doctor make for a better doctor-patient family conference than when the gentlemen come alone. When the gentlemen come alone, they want to talk about the Houston Rockets, and they really don't want to end up having that discussion.
Thank you. Go ahead, Dr. Petaway.
I think that from the physician side, another thing that may be helping is the electronic medical record, because there are so many prompts nowadays, and family history comes up, and patients actually have the ability to fill this out before they come if they'll do it. So I think the electronic medical record is a vehicle that may be helping us to get more information than we used to.
Absolutely, absolutely. And I actually stay in line with that in reference to how we're leveraging technology and computers, and move to Dr. Smith. talking mainly about like artificial intelligence and technology and how that can possibly help with prostate cancer detection and stratification. I think Dr. Pettaway had some information about that maybe a year or two ago in his presentation about how that might be beneficial.
Yeah, absolutely. So artificial intelligence is usually pretty polarizing, and for some people it's pretty scary. But the way I look at it is the same way the internet came along. So there's a very different world before the internet and after the internet. I believe it's going to be very similar with artificial intelligence. I think it's here to stay, and it can be used as a tool for good or bad, depending on who's wielding it. When it comes to prostate cancer screening and detection, there's a lot of opportunities to be used for a very strong positive force for good. So even we talked about the PSA being that first line test for screening. After that, a lot of people will get an MRI, but there's some other tests that can be done, some urine-based tests, some blood-based tests. All of those things require interpretation. Doctors are incredibly important, pathologists are incredibly important, but artificial intelligence can be used as a tool. So an MRI is a picture. It's a picture generated by computers. If a computer is helping to look at the image that the computer generated, it can tell difference in pixel colors that may be a sign of a small prostate cancer. Just so reading MRIs can definitely be enhanced with artificial intelligence. Same thing with what we call pathology slides. So when we take the biopsy of the prostate and we look at that under the microscope, the difference between a normal cell and a precancerous cell can sometimes be very subtle. And while pathologists are trained in picking up that subtle difference, using tools like artificial intelligence can definitely help. And then, like Dr. Pettaway mentioned, even if you take a step back in just something simple as the electronic medical record. So primary care physicians have a lot on their plate. All the different cancer screenings, in addition to high blood pressure, in addition to diabetes, in addition to exercise, in addition to diet, all those things have to be spit into a visit that's getting shorter and shorter and shorter. So having prompts like every time you click into a patient's chart, if that patient is over 40, a little stop message that comes and say, hey, has this patient been tested for prostate cancer? Has this patient has a family history of prostate cancer? Has this patient been tested for prostate cancer? And when they've done that study in certain hospitals, they found that like 1,000 more men got a screening test that they otherwise historically would not have gotten just from that little reminder. It's like you have reminders for everything else on your phone. Having those reminders set up in the electronic medical record can potentially do a lot of good.
Yeah, thank you for that, Dr. Smith. There's a lot of different things going on, and there's a marriage I think that y'all are starting to hear about between the PCP and when you actually get to that point where you may be diagnosed with cancer with your medical oncologist. So that marriage is very important. And with Dr. Pettaway, I want you to maybe talk about effective ways that patients can self-advocate for themselves, because that visit that Dr. Smith refers to that is short, sometimes the patient may actually need to intervene and speak up for themselves when they're wanting to get more information on their individual health.
Yeah, that's true. You know, this is a precious time for you. You took time off work. Physician is limited. So I think it's important to come in empowered. What are the things that you want to get out of this visit? What are the key questions you want to ask? Don't just sit there and be passive. Talk about the things that are important to you that you came to accomplish at that visit. The physician in general should look at that very favorably, you know, because you're then allowing him to focus a little bit more. He'll have obviously his plan as well, but if he knows these things are a focal point for you, then he'll be able to spend more time focusing on that too. So I guess what we're trying to say is that it is really a healthcare visit should be bi-directional. There should be input from the patient, from the provider, and the patient should really advocate for themselves in terms of the things that are really bothering them or the questions that they may have. And don't leave without getting that answer, or at least getting pointed in the right direction. I mean, you have power and you took time off and you want to get things taken care of. Time is short. So Dr. Commenda may actually have some thoughts about that, I'm sure.
My contribution is that when you are planning to see the doctor tomorrow or next week, just like you normally make a small list when you're going for grocery shopping, whether it is a list that you write on a paper, which most of my female patients do, or if it's a mental list that you carry in your head, like all my male patients do, just be comfortable. The male don't want to carry any paper. They have everything listed in their head, and usually they go out of my office and they knock again and they say, oh, I forgot this.
That's right.
Yes.
That's right.
And sometimes they say, oh, my wife told me to ask this, and if I don't is. So to really make the encounter useful to the primary care provider and to the patient, making a list makes it very easy. When you go to the bank, you know you are going to get your $200 and you move on where you go. You have a plan. When you're going to the doctor, have the same plan. Today, I'm coming here, we discuss about my diabetes, my hypertension, and my wife instructed me, we discuss about the prostate. That patient A is my best patient because they have stated their case, they have rested. It's now my time to engage them so that we are able to move on. And hopefully through this engagement, hopefully through the electronic medical records, it can help me remember some areas where I was not able to ask. Now, when it comes to some few tips about how patients may be able to obtain history from their family, especially when they may not know how Uncle David died, Uncle John died, or how even their father died, because some of them, they died when they are young. Fortunately, in our community, there is reunions. One of my patients went to the reunion, and during the reunion, they ended up talking to the uncle who was more elder in age and who seems to be a walking family dictionary for what had happened. So for this patient, it was an eye-opener to everything right and wrong that has gone to their family. So I'm here to encourage all of you. When you hear that your family has a reunion, it's time to carve some time off, go there, talk to them. And when you talk to them, this is not like asking Dr. Google, what are your choices? This is really asking your blood relative, what could have happened to my father, what could have happened to the uncles, and you'll come more informed, more appreciative of the family tree. So the next time you go to see the doctor, you are going there with enough issues in your mind to discuss. I would encourage all of you to spread this to all families, members whom you can talk to at whatever age. Age is not a problem. Fortunately, because of TikTok, even the 20-year-old male, they know something about the prostate, I promise you.
Go ahead.
One thing I just wanted to add, going back to the advocacy portion of things, when you're going to the doctor, that needs to be a two-way relationship, like Dr. Petaway mentioned. If you don't trust or feel comfortable with your doctor, go find another doctor. Most people, when they had their first girlfriend and it didn't work out, most guys didn't swear off women forever. It's not just one doctor that you can keep looking, keep finding, till you find somebody that you trust, somebody that you feel has your best interests at heart, somebody that you feel comfortable enough to open up to, and that should be a relationship, just like all of your other relationships.
Great point. Yeah, thank you for that, Dr. Smith. I'm actually going to stay with you because I was actually curious related to your research study that, you did some focus groups. You did it sounds like the shop. If anybody knows what the shop is, he's smiling because that's what LeBron did in a barbershop and it's a very, very highly accepted way for men to discuss things. They're talking about sports. You're talking about a very, very serious issue, but I think the same idea stands. So from that study, what were the most common barriers that you saw and that you observed as it relates to early detection, prostate cancer screening in general in the community?
Yeah, so talking to black men, and we try to make it a very, comfortable, small environment. Um, Unfortunately, fear is a big aspect of things. Um, as black men, we kind of know that we're at the top of a lot of lists when it comes to health issues. And it's almost an aspect of, I don't need no more bad news. Like, I don't want to go because there's no way that I'm going to get a good report. There's no way that this is going to work out for me. And so there's fear of diagnosis. There's fear of being, being cursed with this disease or any other disease. There's also fear of the exam itself. We talked a little bit about the digital rectal exam, and there's many men who, they'd rather die than get this test done. And it really is very quick, and as Dr. Petaway mentioned, doesn't necessarily need to be the first step. So I tell people, if you just get the PSA blood test, based on that, we can work with it. But you have to come and see us. You have to go to the doctor. So fear is a big portion of things. The other thing is lack of knowledge about prostate cancer. Also, like we mentioned, lack of knowledge about your family history. Like, I didn't know that I was at risk. I didn't know that this was important. I heard about diabetes, I heard about hypertension, but I didn't know anything about prostate cancer. And I didn't have any symptoms. So a lot of times with prostate cancer, you're not gonna have any symptoms. And so it's like, it's not bothering me. I'm not, if it's not broke, don't fix it. But it might be broke, and you just don't know. So that's a big aspect. And then just competing priorities, just a lot of stress, a lot of things going on in your life. The doctor and your own health often gets sacrificed. I got to take care of my family. I can't miss work. I can't do all this. But if you don't take care of yourself, you cannot be there to take care of your family.
I'd like to embellish upon that a little bit. We did a screening study here in Houston several years ago, screened over almost 4,400 men, apparently. And of the men that had abnormalities, we found that black men were very willing to come out and get a PSA test, especially when it was done in a community environment like this, where other family members were coming, another reason to come. They were very willing to come out and get the test. But we found that about 60% of the men who had abnormalities never had follow-up. And many of the reasons for that were multifactorial. But a lot of the things are very, very practical, too. It's like, okay, if I'm going to go get follow-up for something that's not bothering me, now I have to take off work. There are these other driving or compelling issues with respect to being the income generator or other things really took over at that point in time. And so if you're going to come out and get a PSA test, if it's abnormal, this is your trigger to really intervene early. But we found in that study that about 60% of the men didn't follow up. So this is an active area that we're really trying to impact, how to get men to really follow through on that. And it's really trying to make healthcare accessible to the community. So it's very complex issue about getting PSA tested and then getting the follow-up that you need. Because if you get the test and you don't get the follow-up, you really haven't accomplished the goal of what was supposed to happen.
Thank you, Dr. Petaway. Dr. Comenda, go ahead.
I can add that my experience has been that sometimes when I discuss with patients for follow-up, they tell me over the phone, "Doc, you don't understand what I stand to lose." Then I'm like, this is more about your health than the money. And one thing that has helped me win over some is by putting back the responsibility on them. And I always tell them, between me and you, you're your number one doctor. I'm your primary care provider. So this is a moment for you to decide whether the $200 for the day that you're going to miss on that day is more important than your health. But you know that you can come on that day and I'll give you an excuse for work. And that sometimes recovers some of those who are simply unwilling to come. But like Dr. Perwe said, that's really one of the biggest problems. You already know, you have identified somebody who has a potentially elevated PSA, but if they don't follow up, because like most men who look like me say, I'm not bothered by it, I don't have symptoms, why do I want to go? And also plus, as Dr. Smith said, the fear. Fear of the unknown is really one of, I think, one of the areas we need to culturally discuss so that we know how we can maybe find a way to overcome it. I have occasions where patients who have accompanied with their female family member, either daughter or spouse, usually end up convincing a male who has never accepted to have a PSA do it. For me, it's a hooray moment, a thank God moment. But usually, it takes the voice of a family member, who is usually a female, to convince them that the advantages of getting this PSA screen outweigh anything and even the fear. And of course, some of my patients have the fear for the needles. So I'm hoping that there would come a way of doing the screening, the PSA, without having to use a needle stick, which I have a substantial number of patients who simply say, I'm going for it, but then they chicken out.
Yeah, thank you, Dr. Commander. I think that the advocacy of the women that are in the audience, you keep hearing your names, and you're called essentially to duty, as you always are throughout life, is that we need y'all to sometimes give us that swift kick to get to the place that we need to get to possibly save our own lives. So that's needed. I actually will shift to you, Dr. Pettaway, and really just talking about new treatments, new strategies related to prostate cancer, and what you're excited about for the future of us trying to tackle this disease and be as best we can to eliminate it ultimately.
Practical things are one, the messages for early detection. We have guidelines now. We need to really collaborate with our primary care providers to get them the information so that they feel comfortable with counseling men about prostate cancer. They do a lot of things, and this is just one of them. So we need to get them practical information so that they can move that forward. The other practical things are detection of cancer and how to minimize morbidity that we talked about during that. The biggest area in the future, though, is just the broad field of basic research, how that is really helping us to hone our treatment. Nowadays, when you think about cancer therapy, chemotherapy is one side, but now you're looking at more targeted therapies. You're looking at revving up the immune system now. That used to be so weird. I used to think people were kind of like, ooh, you know, when they talked about the immune system. But it's huge now. I mean, immune therapy is like every day now, you know? And again, these targeted therapies, as we learn more about the properties of the cancer, we can use that to take advantage of that. And again, the PSMA is one example of that. There are other cancers where we know that there are certain vulnerabilities based on their DNA, and we can use certain drugs to sensitize them to killing. One big group is called the PARP inhibitors. One of the compounds is called aliparab, and this is, again, helping extend the survival in men who have failed all other treatments for prostate cancer. Not curing them, but certainly extending their survival, and hopefully we're going to get there. But I think basic research is really fueling these discoveries and practice-changing care concepts for men.
Thank you, Dr. Pettaway. Thank you. And this question will actually just go to the group. Just looking at best practices for men out in the audience as we kind of round things off to advocate for themselves, to advocate for their prostate health. Like, what are some things that y'all would just tell the audience that you want to tell the audience about best practices in this particular realm?
So I'll start off. Family history is important. So we talked about you going and talking to your family members about what they've gone through, but also you telling your other family members, especially the generations underneath you, not just what your health is and what you're going through, but encouraging them to go take care of their health and to go to a doctor, maybe do things just slightly better than the way you did it, so that as a people group, we can continue to go forward.
My advice is that fear of a medical diagnosis is real. And in fact, if you don't have fear when you're confronting diabetes, hypertension, or cancer, that is also not normal. But then excess fear in an area of prostate cancer is not going to help. So the best thing is you'd rather have a reasonable discussion with your provider, shared medical decision making. The doctor is not going to do things to you that you don't want. But the education from the doctor for you to understand what's going on will help you, guide you to make a decision. And the knowledge that you really are your own doctor, you are the one who knows mostly what you do, and you sometimes know what you've done wrong. If you know that smoking is related to some of these cancers and you've been smoking for 20 years, or God has given you life, you've smoked for 40 years, that has an effect. The doctor is there just to relate your smoking with what can happen. And the doctor is trying to look at what is possibly going on. But the doctor is not making or forcing you into this corner where you have to make the decision. The doctor is leveraging his education to help you make a decision so that you go home happy and the doctor goes home happy.
Just, I think quickly, what I would say is I would embellish on what Matt said. Find a good primary care provider who really seems to take the time to learn about you and to learn about your health. He's going to talk to you about the things you should be eating. He's going to talk to you about exercise. He's going to talk to you about general health. Then most medical systems these days have medical portals where you can actually see your own medical records. Be your own custodian of your own medical records. Empower yourself. Learn about what your chart says about you. So that is powerful information that you can share with others and family members. So don't depend on somebody else to take care of your health. As Dr. Commenda said, you be your own doctor. You take charge.
Absolutely. Thank you to all of the panelists. And Edith, if we have time for questions, but I'm watching the clock. I've done this a few times, so I'm a good timekeeper. If we have time for questions.
We have about 5 more minutes.
Yeah, so if we have time for any questions, I always like to engage the audience. If y'all have something that's in your mind or something that sparked your kind of ideas on what you might want to hear from the panel about, I'm going to open it up for y'all for these last couple minutes, if anyone has anything to ask. Y'all like me to repeat the question, or y'all heard it okay? Okay, yeah, I know for the audience, I know on the online. So, okay, you can repeat your question, ma'am.
I just said, is there a specific genetic test that you would recommend for men to take, like 23andMe or whatever? Because a lot of times family members are dead. There's no one that you can ask. But if you get that genetic testing, then you know to move forward or not.
Absolutely.
So I can. So from the standpoint of view of tests like 23andMe, they can tell you about your ancestry. Can you hear me? They can tell you about things like your ancestry. Some can tell you about that you're in a risk group for this potential disease here, or that this dietary intervention may help you, or you may have these problems here. It doesn't replace going to a physician who can then personalize that and operationalize that for you to say, go do this, 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 and this. So those tests are good to find out about your ancestry, your family, what you might be predisposed to. But again, when we look at a test, every test that we do is not perfect, right? there are false positives, there are false negatives. So what you want to do is, okay, this test has raised my suspicion level. So now I'm going to go to the physician and talk to him about this. That's a focused visit. And he can say, okay, I've examined you. I've taken your history. I've done a basic panel of blood work, and I think you should do this, this, and this. So he can make it then very specific for you, okay? Yeah, no, yes, there are. There are different tests that will tell you a variety of different things. But we have to remember that no test is perfect, and there can be false positives and false negatives. And then the question is, okay, it told me I'm at risk for this. What do I do about that? So now the physician is going to really help you put that into practice. So nothing wrong with getting the test, but the question is, how do I implement a recommendation?
Thank you.
Thank you.
How y'all doing
Yes, sir.
today? I'm sorry.
Go ahead, please.
How you doing today? My name is DJ Johnson. I'm glad y'all showed up, doctors, Dr. Smith, Dr. Pettaway, and Dr. Thomas. Thank y'all for showing up. Now, I'm in my mid-50s. I don't really go to the doctor or nothing. I think last time I've been to the doctor when I was 20 years old. I come out of Cashmere Garden. We had clinic over there, whereas, you know, your mom take you to the clinic, but they didn't shut down a lot of the clinics. And so by me working all the time, and, you know, I used to go to the doctor just for little stuff. But last time I went to the doctor, they was telling me that my things was higher, you know, and so they had said I was borderline diabetic. So they put me on Mac formula. And I didn't know too much about Mac formula. I take it every now and then because I love German chocolate cakes and, you know, a lot of sweet I was eating. But now I done got old, I had to cut back. But my question is to y'all is, when we do the copay of this prostate, they always say the copay is maybe like 100, 200 on the copay. And a lot of people just don't have the money to do the copay, because when I tried to do it, maybe like about 10 years ago, the prostate, they were saying about the copay. And, you know, we don't have clinics that to work with us. You know, a lot of us guys, we talk, we're like, oh, man, I can't afford it. I have to feed my family and stuff. But it should be a way that we can find where it can be free, like we have today, you know. And another thing, too, before I get ready to sit down, is this. When y'all say PSA, saying about it's supposed to be range of 4, that's by me being in my 50s, is that possible? I mean, being in your 50s, I mean, I understand if I was a younger man, it'll probably be at 4. So can one of y'all give me a kind of clearance? Because like I say, I'm 55, and I just like to know what my PSA should be.
I'll turn to Dr. Commenda to answer some of your first questions, but you're very right about that PSA broad range of 4. That's for the whole population. But in general, if you look at the median PSA value for somebody who's 50, it should be less than 1. So, Dr. Commenda, you want to talk about some of the other?
I just want to assure you that I know that if you look around, there's always a free screening in Houston, annual screening. Today, there's one. I'm telling you, next month, there'll be another one. You just have to put your ears to the ground. Most of the churches here are organized. I have patients from other counties, including Waller County, who actually get the yearly free screens. So if copay is a cost or is a factor in lack of PSA screening, the only alternative I recommend is just look for the free PSA screening, which have been provided, especially in Houston. On the other issue of the medication that you received from the doctor, I'm so glad that the doctor found it appropriate to give you metformin. It's a very good medication. It can improve your health, but I'll encourage you to be compliant. That means do your best to take it every day, because if you actually don't take it every day, the doctors don't like to tell you that you're non-compliant. And when you're non-compliant, It's no different than you taking your car for oil change every 8 months. The effect is the same. But your health is the best gift that God gave you. So for me, I'll say, do the best by taking the medication. Do the best to get the free medical care or free screening, which, thank God, to our location in Houston, they appear to be present at least once a year, and you can get it.
The last thing I'll mention is just a lot of times a patient will go in the clinic or the hospital will say, oh, your copay is $100, and then they'll go, oh, I can't afford that, and just leave. Almost every hospital and most clinics have some kind of payment program, some kind of financial assistance, but you have to, again, unfortunately, you have to be your own advocate in your health. You have to be your own advocate on the finance aspect. You have to be your own advocate because nobody likes you like you do. So, hey, that's too much. What can I do? What can you help me with? What other options are there? You may need to switch to a different, insurance. Whatever it is, don't just take what they give you at face value. Kind of advocate for yourself in that regard.
All right, thank you very much. In the interest of time, we're going to take one more question and we'll move on to the next session.
All I want to do is I want to thank you guys. First off, I am a prostate cancer survivor, member here at the church. I want to thank Dr. Pettaway. I want to thank you because, like I said, your co-worker, Dr. Davis, helped me. On 12/12 of 22 is when I rung that bell at MD Anderson. But I want to thank TSU for what you guys are doing. I'm a big advocate about prostate cancer. Everything that you guys said today hits the spot. And when it comes to us men going and getting that checkup, take your wife with you. Yeah. I'm going to tell you why. They're going to ask the questions we're not asking. And then once they say, hey, you have prostate cancer, your mind shuts down. She can listen, find out everything. And we'll say this before I sit down. It is a journey that both of you have to walk together. So all I'm going to say is you guys are doing great things, and we want to say thank you.
Thank you so much. Thank you so much. A big round of applause to all of our panelists. Please put your hands together for them. All right. Okay. So while they make their way back to their seats, I will be introducing a very special person today, Dr. Esther Olaleye. She is a professor of pharmacology and the senior associate vice president for research and innovation at Texas Southern University. Her formal training in pharmacology and epidemiology were at Johns Hopkins University School of Medicine and Harvard University. She has a strong background and expertise in pharmacology and epidemiology research spanning over 20 years, working on research programs focused on diseases that are prevalent in our communities. Dr. Esther is the principal investigator of the RCMI-funded Center for Biomedical and Health Research at Texas Southern University. We are excited to have Dr. Olaleye share TSU's commitment to the community. Ladies and gentlemen, please join me as we welcome Dr. Esther. I am the only one who has said her name correctly today. I deserve another round of applause. Good to have you, Doctor.
Thank you. Thank you so much. Let's give another round of applause to our amazing panelists and speakers. I feel so blessed to be standing here, and thank you so much to Reverend Atkins for really providing this opportunity for Texas Southern University. This is the best place to have this type of discussion, because guess what? God himself is here. And before I speak about our TSU commitment, I'm going to give you a scripture the Lord gave me. Jeremiah 33, verse 6. It says, I will bring it health, healing, and cure. So always knowing that. And the second thing the Lord reminded me as our great healthcare providers were speaking is that tell the people, I anointed those people to take care of your body. Your body is the temple of God. And he anointed the same way in the Bible, in the book of Exodus, the Lord anointed two special people to work with Moses to build his tabernacle. But guess what? Today, you are his tabernacle. He wants to dwell inside of you. And so we should not be afraid of visiting the doctors, visiting the healthcare providers and doing all those things, all those tests. It is okay, because some people feel there's a conflict between faith and science. There's actually no conflict. It's a beautiful marriage. So please visit your healthcare providers, visit your clinicians, and listen to what they have to say, because God anointed them specially to take care of your amazing body. Awesome, awesome. Thank you so much to our speakers. And of course, I have to say big thank you. Please give it up for Dr. Ajewole and her team, the amazing team. I can't mention names because there's too many people. The team has really expanded. Thank you for your passion. Thank you for your commitment. I recall calling Dr. Ajewole when she was very heavily pregnant. I don't know which number of kid it was, but she said when we're trying to get the mobile coach to really take health to our communities. Dr. Ajewole said, Dr. O, I'm in maternity. I said, girl, get out of maternity. We need to get this mobile. We need to get money to get that van. And we're so blessed to have you, Dr. Ajewole. Thank you for all your sacrifices. Thank you to your husband, Pastor Andrew. Thank you so much. My job is very easy. My job at the university is to bring in the funds. And we've been so blessed. We've been so blessed at TSU because of all the hard work of our faculty, our staff, and our students, to be able to attract a lot of money from the state, from the federal government, to really transform our community. We take on that commitment as a university to really transform our community. In as much as we enjoy our cool science, we love what we do, but we understand that the burden to really move the needle when it comes to changing this really poor outcomes in prostate cancer amongst our African-American men, it's really, that burden is on us. It's on us. So Texas Southern University, one of the largest HBCUs in this country, is really taking this commitment very seriously. There are three major initiatives that the university has rolled out, again, under great leadership, President James Crawford, our leader at the university, the Division of Research, Dr. Penn Marshall. One of the, and our provost, of course, Dr. Goodman, who spoke earlier, one of the major initiatives Dr. Ajewole mentioned earlier is establishing TSU as a clinical trial site. By the way, our university is about to be 100 in about, I think, 2-3 years. We'll be turning 100 in the first clinical trial site, first time in the history of this university. Many thanks to Dr. Ajewole and our RCMI leadership, my colleagues Dr. Wanshe and Dr. Liang and the team, for really making this happen at our university by attracting funds to be able to establish that, but more importantly, being able to attract clinicians to work with us, attracting someone like Dr. Nkechi Ogbo, Dr. Edith, Dr. Jasmine Jones, Dr. Grace, so many of them, Dr. Ivy Pone, to be able to establish this. And more importantly, where's Mark? Mark is our first clinical research. Where's Mark? I don't see him. Busy as usual. So Mark is our first clinical research coordinator that we've had at this big university. But one of the main reasons why we see ourselves as a strategic liaison with our community is not only because we have the trust of our community, but it's because we're sitting here next to the largest medical center in the world. Some people say in the planet, okay? But the point is, we cannot sit here next to the largest medical complex and sit here and keep watching this data that we're speaking about without transforming our community. So many thanks to our university, we've established this. And more recently, I'm happy to announce that we received one of the first one again, our Clinical Translational Science Award with University of Texas Medical Branch. Give it up for TSU. What does that award mean? That award means that we will be able to deploy practical solutions to our community when it comes to things like educating on prostate cancer, engaging our community on prostate cancer, and more importantly, being able to increase the representation of our population in a lot of clinical trials. Because I'm so blessed by Dr. Pettaway, because I'm a pharmacologist, so I truly appreciate you keep saying, targeted therapy, targeted therapy. There's something we call pharmacogenetics. Not every medicine will be effective in everyone. right? And so it's very key that not only do we continually improve basic science, drug discovery, developing new drugs, but we want to make sure that drugs are developed for our community, for people that look like you and I, and that they are effective and they're developed early enough. So that is what the university is doing. That's what we just got this huge award with University of Texas Medical Branch, and that award is led by the Dean of our College of Pharmacy, Dean Mosavin, and a big team of us are part of this initiative. More importantly, as an educational institution, TSU is training the pipeline, the workforce, the next set of physicians, social workers, healthcare providers across this country that will move the needle. Dr. Ajewale's P20 grant is going to be training over 80 students. That was the only grant awarded in the United States, that cycle. So we see the blessing and we see the burden of the blessing, but we're up to the task by the grace of God. Lastly, I would like to mention that there's a huge responsibility on us as a community. You know, they spoke so well about, communicating with your family, getting the family history. But I want to leave you with this idea of generational health. We always speak about generational wealth, but there is no wealth without health. And I think if we can preach this to the people, and when I say generational health, I mean preventative health. So teaching is from how the food we eat, the food we put into our bodies, exercising and preaching this, and our kids can model us and really making this happen and taking on that ownership of your generational health and passing this on. Don't let anybody lie to you. You've been cursed by this and cursed by that. I told you we're in this building. God is here, and he said, I will bring you health, healing, and cure. Now he's telling you, God cannot do for you what you have to do for yourself. So we still have to take care of this vessel, and we have to eat the right food. We have to exercise, and we have to keep advocating for ourselves and communicating with our families. So thank you all. We're continuing. My job is just to find the money, and I feel so blessed that we are truly favored at this university. I'll be honest with you. We're truly favored. A lot is happening across the country, but I'll leave it this way, that we're truly favored, and we will not take this blessing for granted to transform lives. Thank you so much. Thank you.
Thank you very much, Dr. Laleye, for that. We really appreciate that invaluable insight. Now, to go to the next program for today, I will be calling on the TSU debate team for a performance. The Texas Southern University debate team is internationally renowned, started under the leadership of Dr. Thomas Freeman more than 70 years ago. The team attracts approximately 25 to 50 students annually. The debate team office is a popular tourist attraction for visitors to the campus to see the thousands of trophies won by the team and the numerous photos of students in competition around the globe. Thank you very much, and please take the stage.
Cancer is still a rare condition, and no two patients are ever the same.
Each person will react differently to diagnosis and treatment, so there is no set formula for how others should respond.
However, with any challenge, there are certain things that help. The Texas Southern University debate team is proud to make this Reader's Theater presentation, scripted especially for this occasion by head coach Dr. Gloria Batiste Roberts, entitled A Brighter Tomorrow.
Prostate cancer is the most common cancer among men in the U.S. according to the CDC.
Prostate cancer is the second leading cause of cancer deaths in men.
1 in 6 men will be diagnosed with prostate cancer.
1 in 4 black men will be diagnosed with prostate cancer in your lifetime.
Certain things that help to address the challenges prostate cancer presents are
love, Just knowing that you have people around you who care about you, who can empower and uplift you. Sometimes friends can be afraid of saying the wrong thing and opt to saying nothing. However, imagine how it would feel if you have your friends disappear when you are diagnosed with cancer.
Care. Taking time with someone or doing something for another is precious. Knowing that people care about you can, in itself, feel like a sea of support.
Time. Cancer manipulates the time that a sufferer has. Just giving your time as a friend is a wonderful gift, be it to listen, to do something considerate, or to be available for treatment and tests. All are great ways to show you care, and more importantly, that you are with them on this challenging journey.
Cancer is so limited, but there are certain things that cancer cannot do.
It cannot cripple love.
It cannot shatter hope.
It cannot corrode faith.
It cannot destroy peace.
It cannot kill friendship.
It cannot suppress memories.
It cannot silence courage.
It cannot invade the soul.
It cannot steal eternal life.
It cannot conquer the spirit.
Elizabeth Kolber-Ross said, "The most beautiful people we have known are those who know defeat, known suffering, known struggle, known loss, and have found your way out of the depths."
These persons have an appreciation, a sensitivity, and an understanding of life that fills them with deep compassion, gentleness, and loving concern.
Many famous men fought for prostate cancer awareness after diagnosis, including the late actor Sidney Poitier and Harry Belafonte.
General Colin Powell, and most recently Al Roker, weather anchor on the Today Show.
Up until recently, I was among the thousands of men who were unaware of the threats that prostate cancer poses to our health, says Dennis Morris, renowned for his portraits of Bob Marley and the Sex Pistols.
Tony Wong says, "We're calling on Black communities everywhere to bring up the conversation of their health and prostate cancer with their dads, their uncles, their brothers, and their friends."
Benjamin Zephaniah says, "It has always been hush hush in my community. Prostate cancer has always been a bit hush hush because of the way it affects our private areas. No one really talks about it. Instead of prostate cancer, it is often referred to as water problems."
David Hayes says, "The fight against prostate cancer is one that we all can win if we stand up to the facts and take action before it's too late."
The problem is not enough of us talk about this disease. As a Black man, not only am I more likely to get prostate cancer, I am more likely to get it younger. This disease can be treated if caught early, so don't let your pride get in your way.
If you're Black and over the age of 45, talk to your doctor about prostate cancer. Don't wait for warning signs. Don't let prostate cancer knock you out.
I am home now from the battlefield.
Wounded, bloodied, and broken.
And the war rages on. Tears run down my cheeks and drip off my chin.
The poison of war is still running in my veins.
And the war rages on, clutching my stomach, clouding my mind, burning my soul.
To survive combat, I must learn when to fight and when to give in.
And the war rages on, the delicate dance of when to stand up and when to lie down.
The war drums are pounding out their call, and the
war rages on. This war is not over. You must fight again and again and again.
So I join my brothers back on the battlefield. We are a wall of fierce determination.
We will not be denied the opportunity to take action before it is too late.
And we will never stop trying to find a cure for prostate cancer.
We look for a brighter tomorrow.
We look for a brighter tomorrow.
We look for a brighter tomorrow.
Thank you so much for that incredible performance and presentation, TSU debate team. Now I'm going to be introducing the next moderator who will be giving, so I can take a break. All right, so I'm going to be introducing Dr. Nkechi Obo, but quickly before I go into that, I'm just going to leave us with a few closing remarks from me, okay? So in my years of practice as an investigator, clinical research investigator, and a primary care provider, I have noticed something, and I'm saying this off of what our panelists had mentioned earlier. There's an importance of a good relationship between the patient and their provider. Listen, guys, if you don't trust your doctor, please go home and think about it, because what you don't want is for you to get to that point where you have to make critical decisions and then you realize that I really didn't trust this doctor all this while. So please form a very trusting relationship with whoever is your doctor. And honestly, in my years of practice, I have realized that doctors and providers treat patients who are better informed better. The more informed you are about your disease process, the more likely you are to get good treatment. So when you walk into the doctor's office and you have a concern, please, ladies and gentlemen, do your homework. Don't go in there talking about ChatGPT and Google and the rest of that. You need to know yourself better than anybody else. Okay, now the other thing, Dr. Commander had mentioned taking notes to your doctor. Make notes. What is most important to you? As we talk about prostate cancer, we're talking about sexuality. We're talking about mental health. We're talking about family. We're talking about work. What is more important to you? What may be important to man A might not be important to man B. A man who is not married might not be worried so much about his sexuality. Somebody who is living off of generational wealth might not be worried about finances. So when you go to your doctor, please let them know at every point in time, before you get to those critical moments, what is most important to you. The importance of support system is another thing. We get treated differently when we have support system. So don't ever think that you go to the doctor's office and you make them understand that you don't have any support system is going to make anything better. Ladies and gentlemen, I'm going to be ending up on this note, but I want to introduce Dr. Nkechi Obo. Dr. Obo graduated with a Doctor of Pharmacy degree from the University of Minnesota, Duluth, and completed a one-year general practice pharmacy residence at the Michael E. DeBakey VA Medical Center in Houston, Texas. She also completed a master's degree in public health with an emphasis in public health leadership from the University of North Texas Health Science Center in Fort Worth, Texas. Over the past 17 years, Dr. Owo has worked in the retail pharmacy setting and most importantly, Texas Children's Hospital for 9 years before she joined TSU as a health education and community engagement pharmacist. In her free time, Dr. Obo enjoys spending time with her family, traveling, and most importantly, singing at church and even at work. She is also very passionate about educating on financial literacy as well as healthy eating. Ladies and gentlemen, please join me as we welcome the delectable Dr. Nkechi Owo. Thank you.
Thank you, thank you, thank you. Thank you so much. And before I go any further, since I have the mic and I'm the master of ceremony, I think this is the first time I'm being one, Doctor. It's power. It's power. All right. Now, but can I just say thank you to everybody who is still in the room? Thank you. And I don't see that anyone has left. Really appreciate you. It's been over an hour and you're still here. And please let me crave your indulgence to remain in this room. There is still great information being shared, and that will be shared, and I know that it's going to bless all of our lives. Before I think I'm in church, well, I am in church, but in another capacity. All right, without further ado, I'm going to bring up those who will be making up the next panel discussion session, and just a few, but before that, a few housekeeping rooms. To those here on site, in the folder you were given, I believe it's a gray or ash folder, there is a note card in there if you have any questions, but also while this panel discussion is taking place, we will make our time to receive your questions. Depending on how time looks for us, we might be looking at maybe between 2 to 5 questions, but please do crave our indulgence. If there is any question that has been answered here, please give that to me and I'll make sure I relay it to our providers or members of the panel, and then we will relay the answers to you. Also, for our community health workers online and here in person, if you want to receive your 2.0 credit hours for evaluation. Please fill out, go ahead and scan the QR code so you can fill that and also sign in for that. And we will send those credit hours to you within the next 2 weeks. For those on YouTube, please do continue to share this information, and on Facebook as well. And we're inviting you to join us via our social media platforms, also on this QR code. All right, without further ado, I'm gonna invite up to the stage our moderator for this event, Dr. Donald Cooper, who has spent over 20 years as a community leader and dedicated to providing educational and economic opportunities for families and students. Now, as the executive director of the African American Male Wellness Agency, he leads national efforts to promote health outcomes, increase access to care, and also empower men to take control of their well-being. Dr. Cooper received his Bachelor of Science in Criminal Justice with a minor in Sociology from the Southern University, completed his MS in Public Administration at TSU, and later his Doctor of Education in Professional Leadership concentration from the University of Houston. Please, can we give me one of applause? Thank you, and thank you, sir. Next person is Pastor Carl Mendez, who is a dedicated educator with 29 years of experience, including the last 13 years as a principal, as an assistant principal. He also serves as one of the men's pastors at Powerhouse Church in Katy, Texas, and he's the founder of Building Dads, a ministry that is focused on strengthening fatherhood and family leadership. Now, through his work in education, Pastor Carl has witnessed the profound impact of fatherlessness on students and communities. His mission is clear, and that is to help raise boys into responsible men and also empower girls to grow into confident, cherished women. With a heart for mentorship and service, he blends his roles in education, ministry, and fatherhood to inspire lasting change. Thank you, sir, for making our time today. And then our last but not the least panelist here is Mr. Lee Moultrie, all the way flew on the plane to get here. We appreciate you, sir. He is a dedicated healthcare and civil rights champion with decades of experience advancing cancer awareness throughout the United States. Previously, Mr. Moultrie served in the national organization Southwest Oncology Group to ensure that the voice of the prostate cancer patient is being heard with upcoming clinical trials. Mr. Moultrie is also an ambassador of the South Carolina Prostate Cancer Screening Program. His lifelong commitment is improving health outcomes in all communities to inspire change at the grassroots and policy levels. Hey, thank you. I lied when I say last but not the least. Mr. Mitchell, I did not forget you. I didn't forget you. But Mr. Norman Mitchell, my friend, is the co-founder and the CEO of BBZ Wellness Center. And it's a non-profit organization dedicated to HIV prevention, health education, and comprehensive community wellness. He's a former comedian and actor, and he has transformed his life from homelessness to national stages before returning to Houston to serve his community. Thank you, sir. Appreciate that. Since founding BBZ in 2000 with his wife Darcy Paget, Mr. Mitchell has helped secure over $20 million in grants to expand healthcare and outreach programs. Under his leadership, BBZ Wellness Center provides a wide range of services from primary care, dental, mental health, pediatrics, geriatrics, and mobile clinics. He is recognized with numerous awards, and he remains a dedicated mentor and community leader. Please, can we give him a round of applause? And as well as that, he's also been a mentor to us for our TSU mobile unit, and he has indeed selflessly, shared insights since his organization also runs one. So we appreciate you, sir. Thank you. And over to you, Dr. Cooper. Thank you.
Good afternoon. Do better than that. Good afternoon. How everybody's doing? All right. Let's give Texas Southern University another round of applause for this annual event. Definitely want to thank Dr. Veronica again for always keeping me in mind. I think I charged her about 2 years ago to say, hey, we want to be a lifelong moderator. And I think me and Dr. Hunter have met that obligation. So thank you for keeping the alumni in your forte. Thank you. Well, we're going to have a great discussion this afternoon. I want to definitely welcome our panelists today. First of all, I just want to share with everybody, this is a safe space. I think sometimes when we're talking about prostate cancer with black men, as I've learned across the country, a lot of times men, we don't want to talk. So this is a safe space where you could be vulnerable today. Really want to be an engaging opportunity for our panelists to be able to hear from you as well. And so again, we want to just dive right in with this opportunity. I definitely want to thank Mr. Mendez, Mr. Moultrie, as well as Mr. Mitchell for joining us on today for this opportunity to talk about healthcare. As we know, this is a very interesting topic because a lot of men we don't have healthcare. So we know in a safe space opportunity, this is a topic that we generally do not want to talk about because, again, vulnerability, not feeling in a safe space, embarrassment, ego. So, again, as black men in our culture, this is somewhat of a interesting topic sometime. And so we definitely want to dive in to talk to some of our experts on how healthcare has been important to them, but most importantly, how have they navigated through this experience of being prostate cancer survivors as well. So we're going to start with Mr. Mendez. Mr. Mendez, tell us a little about the Building Dads and the supporters for the overall well-being of men in their families.
Well, I appreciate the opportunity to be here. Thank you so much.
Turn that bottom button. Yeah, right. The bottom button right there, huh?
About now? Even better? All right. I was just saying that thank you once again, Veronica, for the opportunity to be here today. I've known the family for a couple years now, and they're a blessing to me. So thank you so much for today. So Building Dads is an organization ministry that just started this year in January. Our goal is to help men be better fathers, be more intentional, be more involved, and be more relational in the lives of their children. We see fatherlessness as a curse on society today. And if fatherlessness is the problem, then what we need is fathers to answer that problem. So that is basically what we do in a classroom setting, but not only in a classroom setting, but we also believe that we take dads out and we teach them outdoor skills. So a lot of times our dads don't know how to fish. We teach you how to fish, and then you teach your kids we give you the opportunity to teach your kids how to fish. So that's basically what Building Dads is all about. Now, funny, as I was sitting here listening to everyone, everybody was describing me. I heard a lot of words out there. The doctor here was saying, they're afraid of getting stuck by a needle. I said, well, check, that's me. He says, you won't go to the doctor unless your spouse takes you to the doctor. Check. We're not going to ask the questions unless my wife says, ask this question. Check. And then I think the one that was the biggest overall was a big chicken, is what you said. Check. So I have found that as I work with dads and I work with men, is that we have a tendency to wait. We have a tendency, if I can endure the pain and I can endure the comfort or discomfort, then there's really nothing wrong with me and I don't have to go to a doctor. So Building Dads is just here to help men change their mindset and being intentional, not just with engaging with your kids, but also being intentional and getting regular checkups.
Thank you so much, Mr. Mendez. You know, that's a very important title of your company, Building Dads, because I think about my dad at 85 years old. I feel like, he's coached me in 50 years of being a dad. But now, as he's now 85, I'm also coaching him how to be a dad in the doctor's office. By being a 3-time cancer survivor, now going through lung cancer, twice prostate cancer, I've walked through every realm of building a dad in this educational space. A dad who moved to Houston, at 16 years old from Arkansas, from the cotton fields, with very little education. This opportunity in my life has given me an opportunity to give back to my dad. And so I applaud you on your efforts of building a company, because there are many men across the country who have not had an introduction of a father or a dad. And so what you're doing is very, very applaudable. We're going now to our next moderator, question to Mr. Martree. And we know that you have been a proud prostate cancer survivor warrior. But we would love for you to tell us a little bit about that opportunity and the importance of being diagnosed early.
Good afternoon. Good afternoon. Can you hear me? Good afternoon, everyone. Thank you, Dr. Veronica, for inviting me to come all the way from North Charleston, South Carolina. She said, well, do you think you can communicate with the black men in Houston? I said, as long as they're men, and I'm 69 years old, I can communicate with them. I'm a 31-year, I retired from the Air Force 31 years ago. I've worked in health, my profession in the Air Force was transportation. God blessed me to come into the healthcare arena for the past 25 years. And the panel you had up here a few minutes, I'm practically in tears because I'm like, these are rock stars. These men that you have up here in the Charleston area where I'm at, I don't get to see that. I don't get to see that. And for the 25 years that I've been doing health education on the university level without a degree. And it's important that I say that because some of the language that was used in the previous conversation, some may have thought, well, I have to be a degreed person to understand this and not work through this healthcare system. But I like what the doctor said a few minutes ago. The more knowledgeable you are when you go to your provider, the more access and information you get. So when I got diagnosed with prostate cancer in 2015, my first screening was in 1995 at 39 years old. So I was being screened for 20 years before I got diagnosed, and I was diagnosed based upon a urinary problem. So I'm skewing all of the data that may be out there, okay? Now, at the same time, when I got diagnosed, the presentation Dr. Pettigrew had there is excellent. The thing that we looked at was I went into active surveillance for 6 years, meaning I got diagnosed in 2015. I didn't have treatment until 2021. Active surveillance. Now you asked me the question, what did that diagnosis mean to me? Nothing. When my wife and after we had the conversation with my doctor, which was a close friend of mine, we prayed together and so on and so forth. So we driving home, I said to my wife, what did you understand what the doctor said? Nothing. Now that was good. Because I called the doctor up and said, Doc, I'd like to have a conversation with you because my wife didn't understand anything you said in that presentation. And you know what he said? It ain't me, Mr. Moultrie, it's the nurses. I said, okay. He said, set up an appointment, talk to the nurse navigators. I set up an appointment with nurse navigators. You know what they said? Sir, we are just regular doctors. They told us we're nurse navigators, but we don't know anything about prostate cancer. So at that particular time, I helped them set up a protocol on how do you communicate with the patient and the family. Again, non-degreed. Okay? Don't use that as an excuse. Before I go any further, I'm going to pass the mic to the next person. As a health educator, there are certain things that I know that are missing. Like someone was talking about the health history a few minutes ago. So what did I do? I went to each of your vendor out there and I asked them, do any of you have a health history guide that people can create? No, sir, we don't have it. So from now on, when you have vendors come, you know what they should be having for your constituents. I sent Dr. Veronica and Cassie an email with everything you will need from this point forward on how do you communicate with your doctor, the questions you want to ask them, the different federally funded clinics you need to be connecting with. What are the different books you need to be communicating to change your mind? Because if you know anything about Houston Rockets or whatever sports there, I know nothing but sports. Praise Jesus. I'm a warrior. So everything is in that email. The number. So that's it right there. I'll go to the next question.
Well, definitely thank you again, Mr. Mocher, for making the contribution of making the trip today with us, but most importantly for just your dedication of what you have been to provide. We definitely want to thank Dr. Veronica. We know that she will do her due diligence for making sure that she shares that imperative information that you share with her. Moving right along to Mr. Mitchell, someone that I look up to dearly as a mentor. We do a lot of community work together in the Be Busy world of being a community-based partner with my organization. But you also have played a vital role in your family transition. So we know in this prostate cancer world, someone always needs a supporter. And you have been that supporter for someone dear and loving in your family. Tell us a bit about how has your role as a supporter been walking through that process, but most importantly, what was that journey like for you?
So thank you very much, Dr. Ajawole, you, Dr. Cooper, and all of the people that have been here so far. I'd like to ask a question before I answer that question. Anybody in the room who has a history of prostate cancer, whether it's a family member or you yourself, just give a hand. I want to see how many of us in the room. So if you understand what we're looking at right here, we're looking at the number of individuals. The graphs are cool, and I think they're great, and I think they do present information. But this is real. And when you talk about the family member I had, my father, several of my uncles were diagnosed with prostate cancer. My dad was diagnosed with prostate cancer in 2011, 2012, and he opted for no treatment. He said, I don't want treatment. I don't even want to do it. My question with him was, Dad, why? Come on, man, you're young. Like, let's do this. We can get this right. He said, I don't want to go through what I saw my brothers go through. I don't want to wear that bag, and I don't want to deal with the pain that they had to deal with. And I watched that man, the strongest man in the world to me. I'm a father. I have 5 sons. And I watched my father go from the strongest man in the world to a broken man who was barely living. And I share with you that it's a painful thing to see. And so if you understand that it didn't have to be that way, you know, if your right arm causes you to stumble, believe it says cut it off and throw it away. So removal of the prostate cancer at his age, or removal of his prostate at his age, would have been a great thing for him to do. He wouldn't have had to suffer that way. But again, when you have a lack of access, we did go to the hospital. We went to the doctor, and the doctor said, well, let's have a cancer conference. No one wants to conference with cancer. He said he had about a 29 or 30% adherence rate for people coming to the conference for cancer. But I said, why don't you call it a family conference? You'll get more people to attend. Like, we want a conference about our family. And when they did that, we went back to his next visit, and he said, oh, man, it's been great. We had over 80% people attend. Well, yeah, it's because you had people to attend. You didn't have a thing to come. You had people to come. And I think that, you know, with the brilliant, the brilliant doctors that we've had here today, and, you know, we have something unique here in Houston. The issue is, like that gentleman said, it's the lack of access to it. And we have to do a better job at promoting our access to care. I'm the CEO of a federally qualified health center. Like he just said, federally funded health center. I'm available to you. I'm not the only one, but I am available to you. I want you to know that our clinic is available to you for whatever your services are. And we do have, as was stated earlier, there are, you know, funding streams that pay for persons like you who come in, who need care, who don't have enough to pay for the visit. We can work with you. And that's what I'm about, the community. I'm about the people that look like people in this room. We're here to help the people that look like us. And so that doesn't mean we're excluding anybody, but that means we're going to first look out for the individuals that look like us, because we know lack of access to care is one of the leading causes to every single disease there is. So with that, I'll pass back.
Thank you so much, Mr. Mitchell. Again, you're doing some very great work, and I'm a true witness to be able to sit in your clinic at least twice a month, with our research study that we're doing in partnership with you to see the viable bodies that you're changing, on a day-to-day basis. So definitely thank you for the good work that you're doing here in the community. We're going to go back now to Mr. Mendez to ask you a very critical question, because you've also been able to develop some best practices, and we would love for you to share. What are some of those healthy-related conversations that we call as best practices that could be transformed and communicated to men as well as their baby young boys throughout the city?
So I'll share. You talked about being transparent, so I'm going to share personal experience. In February this year, my oldest son got married. So around the same time, in our classroom with Building Dads, we were talking about the importance of physical and mental health when we're talking to dads. So I'm at the wedding. I'm looking at my son, enjoying, a new bride, etc. Then I look down the aisle, and then I see my daughter, who's 14 years old, okay? And I had just come out of the class, Building Dads, teaching them, hey, we got to be cognizant of our health as men. We have to be. And I'm looking down the aisle, or down the road, and I see my daughter, and I said, you know what? I need to be around to walk my daughter down that aisle. So it became real to me at that moment. So I said, if I'm telling my men that they have to go see a doctor, and I'm not going to see a doctor, then there's a problem, okay? So I go see the doctor, get your yearly physical, and lo and behold, my PSA came back a little elevated, okay? So what do? Tell the wife. We go, see the doctor, puts me on some meds, and then he says, okay, we're going to check your blood level again, and based on what he did, it dropped significantly. So what I learned from that is this. When I'm teaching men, when I'm teaching my own kids, there's a phrase that I go by. My kids may not always do what I say, but they will always do as I do. So as a father, not only do I have to speak life to my kids, but I have to demonstrate the action of me speaking those words. So if I tell them, hey, sons, you got to go to the doctor, you got to stay up on that, well, they have to see their dad going to the doctor. They have to see their dad taking care of themselves. So one, it's a mindset. Two, it's a teaching of men. It's a teaching of my own kids about the doctor. And it's also a demonstration of, hey, you know what? If dad's going, then I got to go. So for me, that is where I focus on. I have to demonstrate to my kids, to the men I'm teaching, hey, I'm doing it too, and it's important. One thing I want to add, you talked about family history. I grew up with no father. My mom and dad divorced when I was 2 years old, never saw my dad again. So I have no idea of what my family history is on the medical side from my father. So even more so, me getting into the doctor, me getting those regular checkups, and then my sons getting in there, because we don't know what is on my dad's side that's being passed down unless we go and get checked. So that's my answer.
Hey, that was a very, very good analogy of what you gave, and and it relates back to some stories that I've had with my dad's doctor. Walking the dad through 2 rounds of prostate cancer, kidney removal. Now wears a lifetime colostomy bag. Now going through his 3rd round of lung cancer. As being the only child, asking my doctor, my dad's doctor, how can I get ahead of some of these, these best practices? And the best thing he said was make sure that your body, as an African-American black man, is in the best shape, because the likelihood of you getting older, you're probably going to really see everything known to mankind. And so, best practices in our family conversations become very, very vital in the day-to-day practices. So thank you for sharing that, Mr. Mendez.
Yes.
Going over to Mr. Moultrie. Mr. Moultrie, when it comes to maximizing health-related outcomes in prostate cancer, what factors would you like for men and their support systems to be mindful of?
As you ask that question, I need folks to understand it's very, very, very important as we're dealing with the caregivers, and the patient themselves. One thing I learned when I went to treatment was that, yes, I had medical coverage. Medicare covered 80% of my bill. The military covered the other 20%. But I still had to pay, I still had to live out of state. I live in South Carolina, but my treatment took place in Florida. So I had to live in a short-term rental for 2 months, $1,600 a month for one individual to stay for 2 months. But my treatment, as Mr. Mitchell said a few minutes ago, his father didn't want a particular procedure. Well, I discovered this book in 2021. You can beat prostate cancer and you don't need surgery to do it, better known as proton therapy. It is non-invasive treatment, low-dose treatment. It has been approved by the federal government since 1988. It's in 46 treatment centers throughout the United States. But unfortunately, it has been kept quiet for some reason. Okay? Again, I only discovered this after being in the health arena for 21 years. And I happened to be on a Zoom call with some guys out of New York, a prostate cancer support group. And I said, what the heck is this book? They said, don't worry about it. Get the book and you'll find out. Okay? This is non-invasive treatment for prostate cancer and 20 other cancers. It treats breast cancer, pediatric cancer, throat, everything else. It's because we are not investigating other things. We are not exposing ourselves to different cultures, other people. Well, I don't want to be a white people. I just want to be a black people. No, don't do that, dog. Don't do that. It don't end up well, okay? I expose myself to so many different groups because people are discussing other things. And so the one thing I learned about health insurance is one thing, medical. But if you get life insurance with living benefits to help you with things that your medical don't cover, you'll be okay. You'll be a little bit better.
Thank you so much, Mr. Morshey, for that outcome, because, you know, so many times in our inner city communities, these are conversations that we're not having. And a lot of times it comes from, you know, historical data. You know, our fathers didn't have health insurance. And so, you know, now that you're growing up and Mr. Mitchell talking about raising 5 young men, I'm pretty sure there's some times where he's talked to his boys about a day when he did not have insurance and how it's important that now they are growing up and taking care of themselves. It becomes very, very vital in today's society. Let's move to my next question, Mr. Mitchell. You talked about early on about you being a very vital role in a supporter system to your father. But what conversations can you encourage today, as we know that early detections save lives? In your day-to-day world, you have 5 sons. What words of encouragement can you give today to talk about the importance of early detection and getting screened for prostate cancer?
That's an excellent point. Early detection equals prolonged life. We know that. Yeah, I think that, you know, we don't talk about it enough. Not just, you know, in terms of prostate cancer, but in terms of all health conditions. We don't talk about health and wellness enough in our own communities, in our homes, at work. You know, we don't talk about it at the barbershop anymore. That used to be the spot that we actually went and engaged in. And now it's not that much, you know, because the barbers are younger now. So they don't have the conditions that the barbers had when I was growing up. And so, you know, it's important that we take these conversations. I actually spoke about this event at the barbershop on yesterday, and 2 of the individuals who were being cut in there, each one of those individuals said, well, yeah, I had prostate cancer. I opted to have my prostate removed. Or the other gentleman said, well, I'm going through treatment right now. And that was in the barbershop just on yesterday. Imagine if I had had that conversation a week ago, 2 weeks ago, a month ago. Imagine the challenges that we could have overcome. So again, you ask about early detection. Early detection is going to change when we talk. We have to talk. We have to encourage our communities to talk. We have to encourage our families to talk. And yeah, the women are going to talk for us. That's what they do. It's not a bad thing, but they're going to do it. Another thing is let's change the language. So I think digital rectal exam is confusing. And let me tell you why. Because the word digital sounds like some type of a device. And see, that's what I thought when I went in to get my digital rectal exam. He started putting on the glove, and I was like, hey, wait a minute, where's the machine? He was like, what machine? And I said, the digital machine. He said, oh, no, these are digits. So I learned real quick what digits were. So I got that. I understood then, and I realized how important that test was. So, as a 60-year-old African-American man myself, I can tell you, that it's something that we do have to engage earlier. I started being tested at 35. I want to say I had PSAs at 35. My numbers were really good until recently. COVID kind of changed a lot of that stuff for me. But again, early detection. If you think you need to get tested, get tested. If you don't think you need to get tested, get tested. If you know somebody that you think might not need to get tested, get them tested. And go with somebody. Be the support that you want someone to be for you.
Thank you so much, Mr. Mitchell. In my day-to-day world, I get a chance to travel around the country, and we have a program within our institution what we call Real Man, Real Talk. And I was leaning over earlier talking to Dr. Matthew saying we want to partner with him and what he's doing, the great work, MD Anderson, because we're going to be doing barbershop talk for a 12-month series next year. Just going into the barbershops, having that random conversation that we used to have. We used to call it the country club, at the barbershop Saturday mornings where you couldn't miss a conversation about men having that peer-to-peer support system. So definitely thank you for Mr. Mitchell for what you're doing across this city. We want to pivot. We got some time, but we want to pivot from some of our questions and get you involved. We know you've been a very tentative participant today, but we may have someone in the audience today. Again, this is a safe space, so we want you to feel vulnerable to share something. But if you have any questions, let's entertain maybe 3 questions, men or women that have a question. Got a question in the back? I'm going to bring a microphone to you.
So, what do you do that you've had 2 biopsies over a 5-year period and they found nothing?
So two biopsies over a 5-year period and they found nothing. What do you do? Anybody from the panel can answer.
Celebrate. I would say celebrate and then pass it to the provider. Yeah. Celebrate.
So,
Dr. Matthew?
So if your PSA may still be elevated, what do you do?
We're gonna let Dr. Matthew. I got you, Dr. Matthew.
Yeah, Doc spoke about that earlier.
Yeah, so like we mentioned, PSA can be elevated for a number of different reasons. So it's usually the first test that we get to let us know who is and who is not at increased risk. So if you have an elevated PSA and you get the biopsy and it turns out to be negative, number one, like I said, that's great. There's some other tests that we can do to kind of risk stratify you. So I don't know if you had an MRI. There's some other tests that confirm MDX or things like that you can be placed into different buckets or categories to see whether you are at higher risk and whether you need a repeat biopsy or whether you just need to continue on with the PSA monitoring. But so there's some other things that you can kind of go through so that people can keep a closer eye on you and make sure that that negative biopsy result is a true negative and not a false negative. Dutasteride?
Sir?
Dutasteride?
No, it begins with a T.
T.
And I can't
Tamsulosin.
Probably so.
Okay.
So, how long do you take that? And at what stage do you stop when you get your prostate to the proper size, if there's such a thing?
All right, so tamsulosin is more so for enlarged prostate symptoms. It kind of opens up the middle part of the prostate so that men can urinate easier. And it's a medication that as you take it, it keeps working. So a lot of men are on that medication either for life, or there's some surgeries or procedures that they can get to open up the prostate instead of that medication. It kind of opens up the middle. There are some other medications that can shrink the prostate a little bit, that sometimes are taken in combination. But if you're on those medications, it's most likely due to symptoms. And so then as your symptoms change, get better or worse, that's when you start to determine whether or not you continue or discontinue those.
There was an article in there indicating that a urinalysis for prostate was available through a urinalysis test. Is that some modern test that they're studying, or is it really authenticated?
So urinalysis is a specific type of urine test. There are some other urine tests that are specific to prostate cancer, PCA3, Select MDX, those types of things, for people who already have an elevated PSA, again, to try and risk stratify them or put them into different risk buckets. And so those are, and there's more coming. So there's a lot of research in this area on how can we best split up men into, these are low risk, these are medium risk, these are high risk, and try and prevent too many people from undergoing a biopsy that they didn't need, while making sure that the people who do need the biopsy get one.
Good afternoon. I am the caregiver and supporter and part of a cancer ministry. I have a family member who was diagnosed with prostate cancer a few years ago. He's now in remission, but at what I'm hearing is get tested at between 40 and 45. He had a son that was in his late 30s. So I hope that narrative will change. And then we found out his brother was infected with the cancer, and all of the men on his mother's side, grandfather, uncles, had the cancer. But he did not find that out until he was diagnosed. So I'm just hoping that that age 45 is just say, know your family history, and when you go, or if you go for a medical checkup, please include the tests.
Thank you. No, one question right behind you.
Good afternoon. This question is for Mr. Lee Moultrie. Lee, you and I have had lots of conversations. I want you to kind of share information about diet and physical activity and what you do to, give men some tips.
Okay, thank you, my good friend. She said we had a lot of conversation. She be my mentor from 25 years ago. She mentored me in this industry, in this arena. Once I got diagnosed with prostate cancer, the doctor said, Lee, there's a couple of things we would like you to do. Exercise a little bit more and adjust your diet. So what I started doing, going to the gym, exercising, and if you don't have a gym, don't worry about that. You can walk in the street, you can go in the malls and so on and so forth. So I went to the gym and I started exercising 5 days a week, 30 minutes, or went up to more. Even got crazy enough to doing spin classes at 5:30 in the morning. Lord Jesus, that's a crazy black man. I was doing water aerobics and so on and so forth. So you can also, and my diet is being from the South, South Carolina. My diet stayed the same, but I prepared my food differently. I still ate collard greens, cabbage, okra soups, but I prepared them different. What they would call it today, Mediterranean diet, that's basically what it was. I still ate meat. So you want to make sure that you're incorporating those things, but you want to make sure you stay away from processed food and ultra-processed food as much as possible. Now you would say, okay, how would you prepare collard greens without all of the other stuff? You just do that. You got the greens, you put a half a green bell pepper, half a red bell pepper, and you got that right there. Your cabbage, I prepare my cabbage. All I put is some onion in there, and I'm good right there. the okra soup, that's the most healthiest one because I got the okra soup. I got the okra, you got tomato paste, then you got all of the colors of the bell peppers, celery, onion, and so on and so forth. And then you're only using about a half a cup of brown rice throughout the day. You're exercising. You're doing about 30 minutes exercise per day, about 43 minutes, the maximum I can do. People say, well, why you can't do an hour? No, because they say it's 3 hours, 30 minutes is adequate maximum exercise per week. Me being from the hood and being a brother from the hood, I said, that's 43 minutes, that's it. So I do 13 minutes on the elliptical, 10 on the treadmill, 10 on the 10, that's it. I ain't doing no more. So that's 3 days of cardio, 2 days of strength training, half the upper body one day, lower body the next day. 69 years old, I'm still doing this stuff. I got other guys in the gym who are 84 years old, 77 years old. So we're talking about this longevity. So we talk about longevity. Dr. Atiba talks about longevity, how your last 10 to 20 years should be your healthiest years, or it will be your most expensive years. Okay? This is real, brothers and sisters. This is real, so you have to do it. Let me throw this right here real quick before we get shut down. I have this book right here. It says Field Guide to Men's Health by Dr. Mills, who created the UCLA's Men's Health Center. He is the consultant to the Los Angeles Lakers and Dodgers. This is what he says. I don't preach to my patients. I dialogue. I tell the men who see me in my office that we'll be spending only 45 minutes a year together. So the remaining 364 days, 23 hours, and 15 minutes are up to them. I coach men to invest in their health. Brothers and sisters, and I would say he's talking to women too. As I was talking to the doctor before we came in here, we're in a church. I've been in the household of faith for the past 38 years, okay? In the church, we're not talking about your body as a temple. Why are we not preaching about that? Because you can be more proactive with that. It said, my people perish for the lack of knowledge. Why are we not educating them? When I go to church, you know what they tell me? Well, Brahma, you got 3 minutes, man. You got 5 minutes, man. I'm like, what? Pray for me, people. Like I said, I've been black for 69 years. Oh, in the barbershop, I just did a barbershop talk 2 weeks ago. One thing I learned that's going to blow your mind. I said, in the discussions, we need people from 9 years old up to 70. They said, you want to talk to a 9-year-old about prostate cancer? I said, no. I want to talk to the grandparents and the parents about that child for HPV. Okay, but you know, I was telling the barber that these are commercials on TV. And the barber said, Mr. Moultrie, that's not on TV. I said, no, sir, it's on TV. I said, it's a black woman talking to a young man, and it's a white man talking to the 3 kids in the back. No, sir, it's not on there, sir. It's not. And you know what he said? Oops, I apologize. He said, I pay a subscription service not to have commercials on my TV. No, this is serious, people. He not being educated. All of you who have subscription service, you're not being educated. You're being entertained. We are trying to get health messages to you, and you don't understand that. If your football team love you, like I told you, I don't know nothing about sport. If your football team love you, why y'all don't see no health messages there? Your basketball team love you? Why you don't see no health messages there? If black men dying at the highest rate from prostate cancer, why don't I hear that on Steve Harvey's show? Why I don't hear that on Ricky Smiley's show? Why I don't hear that in the church? Why I don't hear it from the fraternities? I've been doing this too long, brothers and sisters. I told you I'm a warrior. I'm a fighter. And if you ain't doing what you're supposed to be doing, God blessed me to come here to tell you we need to make some adjustment. That's all it is. Let's be real. We can't blame some of this is, yes, systemic. But some of this we got to own ourselves. I just read it to you. Men and women. Don't blame nobody else. What are we going to do differently from the moment you leave here today? And as I said, Dr. Veronica got the thing. I got 14 different books you can be reading, websites you can go to. A matter of fact, from this point on, if you're ever diagnosed with cancer, the number one organization you want to call is the American Cancer Society. And if you want to call them right now, you can call them now. They are available 24 hours a day, 7 days a week, 365 days a year. The number is 800-227-2345. Any aspect of cancer you want to know, any aspect of nutrition you want to know, there's a counselor sitting at 3 o'clock in the morning. Don't call your pastor at 3 o'clock in the morning. He or she don't want to hear you that time of morning. The Jesus might not come out of him or her that time of morning. But please, seriously, that's the best thing. If you want to know what to ask your doctor before you go to them, call the American Cancer Society. They will email you that information. Even if somebody may not be documented or whatever, we have that information. Federally qualified clinic, all that stuff. But that's it. Thank you.
Can I just say before you say that? Can I just say this to everybody? Please stay away from seedless fruit. No, I'm serious. Seedless fruit is not real fruit. The word fruit, if you look it up in the dictionary, it has seeds in it. So if they take the seeds out of that watermelon, even though it's convenient, what is it? Because it's no longer a watermelon and it's no longer fruit. So stay away from this food that they engineer and manufacture. They say processed food. That is a processed food. So don't put that in your body because it doesn't belong in your body. What belongs in your body is what grows on the tree. What grows on the tree comes from a seed. That seed is what's supposed to be in there. Spit the seed out. Don't worry about the inconvenience of spitting out the seeds. Spit out the seeds. Don't eat that. I'm telling y'all, don't eat that food.
As he said there, and you got to be careful with this stuff. This stuff sounds so cool and so chic. Meatless meat. It's better known as chemicals. Like we said, we got natural food, we got processed food, and you got ultra-processed food. That's why children today are being diagnosed with early onset diseases, because we as the parent and grandparent are feeding them this stuff because they're not old enough to work yet, so they ain't buying their own food. Okay? So this is what we doing to our children and grandchildren. Praise Jesus.
And the church said,
Amen. I was just about to say that.
So
I tell you.
as a moderator, we want to definitely thank Mr. Mitchell, Mr. Moultrie, Mr. Mendez for this wonderful and powerful segment of today. Thank you once again.
Thank you so much. Please, you can. You know what? Actually, I need some of you. You know what? Give me a second if you don't want, before you step down. The next thing on the agenda here is to honoring the prostate cancer warriors, caregivers, and healthcare providers. And please, it's not all exclusive. It's not all inclusive, I should say. So forgive us if your name is not here, but we're honoring everyone also who took time to make it here. So Mr. Lee Moultrie, we're going to be honoring you as well as a prostate cancer warrior. Mr. Norman Milcher, we're going to indeed honor you also for being a prostate cancer champion. So he will be there. And Ms. Calandria Davis, I am going to read your bio because we have not yet read and learned about you. If you don't mind standing up and coming to the front, we appreciate you, ma'am. Please give her a word of applause. This prostate cancer screening you're seeing today, it's all by her hard efforts, and we really appreciate you, ma'am. Now, Ms. Davis is the Clinical Health Services Program Director for Harris County Public Health. She has a bachelor's and master's degree in social work. Thank you, ma'am. She was diagnosed with breast cancer at 33 in 2015 with ER double positive ductal carcinoma in situ and lobular carcinoma, DCIS and LCIS. She underwent 4 surgeries, totaling 26 operating hours and a double mastectomy. Ms. Davis is currently cancer-free and going on 8 years. Amen to that. Her strong work ethic started when she began her supervisory career early at the age of 19 at California State University, Los Angeles, working hard, building her career, balancing her family, and hoping to expand it when she was told you have cancer. Now, not only did this news slow her down, but it helped change her perspective on life and refocus her priorities on what was important. Ms. Davis has been a consistent champion for cancer screening and prevention, as evident in her leading the way to pilot PSA testing on Harris County Public Health Mobile Unit in collaboration with TSU. And this is going on at least 2 years. So please, can we appreciate her again one more time? Thank you so much, Ms. Davis. We really appreciate you. And then also, Reverend Lamont Atkins, we thank you also for being a prostate cancer champion. Please, where is Reverend Atkins? Miss Edith, can you help me look for him, please? I think he's somewhere down there. And then also, please, Mr. Mitchell, if you don't mind standing, Mr. Lee Moultrie, and our other panelists, please go ahead and you can have your seats. Thank you so much. Thank you so much. Dr. Ajewole Muema, I'm going to have you come. Oh, thank you. And she's going to indeed say hi to our... No, we're taking pictures, Dr. Yes, I'm calling you Dr. Mitchell, yeah. Yes, sir. Thank you. We're waiting for one more person. Edith went to look for Reverend Atkins. It's right on our behalf. Yes. All right, go ahead. All right. Awesome, thank you. Dr. O, can you go and join them, please? Dr. Pettaway, if you don't mind, Dr. Commander. Dr. Smith, if you don't mind, for all the great work you guys do. Thank you so much. And we're also going to take more pictures at the end, and if you do, so thank you all. Thank you all. Please, can we give them a round of applause as they go back to your seats? Thank you so much. Thank you. Last but not the least, I'm going to be going on our... Oh, yes, that's right. Now, we have a few more people would like to honor. Thank you, Dr. Ajewole, for bringing me to my remembrance. Please, for anyone who is a prostate cancer warrior in this room, can you please rise up on your feet as we stand up, as we keep clapping for you. Any prostate cancer warrior, please, we want to appreciate you. We have some gifts for you that we specially prepared. Thank you. Miss Cassie, go ahead up. Thank you. As well as a support system. I believe that I saw you, please, if you don't mind rising up to your feet, can we also clap for her, please? We have some goodies for you to appreciate your efforts. This pales in comparison to the work you know and the support you provide, so we really appreciate you. Thank you. I think we have two, one here and one there. I appreciate. Did we miss any warrior or support system? Thank you all. Appreciate you. And if you're shy and you don't want to be recognized out in the open, please feel free to meet one of us after the end of this, and we can also give you a package. Thank you. And I'm going to present, bring to the stage, even if she is not here in physically, she's here with us in spirit. Dr. Michelle John is, she is the inaugural Vice President of Research and Innovation at TSU. She has served as the co-PI for the Maximizing Access to Research Careers and the Undergraduate Research Training Initiative for Student Enhancement, which is also called URISE, both designed to expand the number of students in STEM who earn a PhD or MD-PhD degree. Dr. John received her BA and MS in biology with a concentration in environmental science from Hampton University. And she also received her PhD in community nutrition from the Department of Human Nutrition, Foods, and Exercise at Virginia Tech. So even if she's not here with us, she has a video recording and she's going to be giving us her closing remarks. Over to you. Do I have? Okay.
About prostate cancer.
Okay. So we're going to start that again if you don't mind. Okay.
Hello, everyone. I am Dr. Michelle John from Texas Southern University. And although I'm unable to be with you in person today, I want to thank you for allowing me a few moments to share some closing reflections. Today's face-to-face, shoulder-to-shoulder, Let's Talk About Prostate Cancer event has been nothing short of powerful. We've heard from medical experts and community leaders, and most importantly, those directly impacted by prostate cancer. Your presence, your stories, and your advocacy have made this gathering meaningful and deeply inspiring. To our panelists, presenters, and performers, thank you for educating us, challenging us, and reminding us of the critical work ahead. And to our honored warriors, our caregivers and advocates, you are the reason we do this work. Your courage and strength fuel our commitment to improving health outcomes in our communities. This morning was more than a series of presentations. It was a call to action. Let us not leave these conversations behind once we walk out of the room. Let's carry them into our homes, our clinics, our classrooms, and our neighborhoods. Whether it's scheduling screenings, supporting a loved one, advancing clinical research, or spreading awareness in our communities. Remember, this is not the end of a program, it's the continuation of a movement. Even in my absence, I stand with each of you in this fight for equity, awareness, and access. Thank you for being here. Thank you for your continued efforts, and I look forward to the impact we will make together in the months and years to come. Wishing you all continued health, strength, and connection.
Thank you so much, and we thank her for just taking our time to make this recording, even though she wasn't able to be with us here in person. Then on to what we've been waiting for, right? Closing announcements from Dr. Ajewole Muema. Please, even as she closes us out, don't forget, please avail yourself of the services provided by Aetna as well as Harris County Public Health. For every man who is here, please, as long as you are above 40 or above, please avail yourself of the services there. Thank you.
Thank you very much, Dr. Obo. We are really grateful. Wow, what an amazing, What an amazing session. How many of you agree with me that this session, the past 3 hours, has been nothing short of amazing? And thank you for those that are in the room with us for the past 3 hours and those that have stayed with us online. A big thank you to all the speakers, panelists, Mr. Moultrie, everybody that has just done an incredible job sharing with us this morning and even into this afternoon. How many of you all would like us to have this again? I am excited and I am ready. And did you all notice that next year we've called it Let's Talk About Prostate Health? Right? Because that is really where it should stem from. Prevention, early detection, and let us normalize this conversation. So by God's grace, September 12th, 2026, we will be having another amazing session. But between now and then, we've had a lot of information today that really we should not just keep it within us. We need to then take these conversations to the barbershop, to the salon, to the church, to everywhere and anywhere that we go to be able to advance health for every one of us. I have a few other announcements. I know I'm standing between lunch, but hey, ladies, we have been recognized today, right, in many of the conversations. Next month is Breast Cancer Awareness Month. And as tigers in TSU, when a tiger sees what they don't like, what do? We roar. So October 31st, by God's grace, we will be having our annual We Roar Against Breast Cancer on the campus of Texas Southern University. A lot of great speakers, a lot of panel sessions, great resources. So please share this information with your loved ones. The registration is already open. Scan the QR code, join us. In person preferably, but also online as your schedule allows. I would move on now to say, well, some people don't know that men can also have breast cancer. Yeah, as rare as it sounds, we've seen quite a few people, men, that have breast cancer. So December, by God's grace, over lunch, it's going to be a virtual event only. We will have a conversation about male breast cancer. So please save the date. More information, the registration link will be open soon, and we will be spreading that information. Now looking into 2026, TSU community work, we have a lot of, great events lined up ahead of us. January 30th, Friday, we will, by God's grace, be hosting our 4th annual maternal and child health education and outreach. This is where we talk about mothers. This is where we talk about babies. The data around mortality and morbidity for women in the Houston area, especially women of African descent, is also not looking great at all. So we will continue to have that conversation. Please save the date, spread the word with your loved ones to join us in person preferably, but also online. Almost all through today's conversation, we've talked extensively to some extent about clinical research. TSU again stands in that pivotal position to share information with the community about clinical research. By God's grace, April 18th, please save the date, April 18th, 2026, we will have our annual clinical research and engagement conference. The link to register for all these conferences will be opening up soon, and we will be sending all those information by email and on all our social media platforms. Lastly, for any of the community health workers in the room and online, don't forget to complete your evaluation so that way we can send your certificate for your CHW CE hours. And please continue to join us in sharing the word and spreading this information across all platforms. I want to say a big thank you again to all my team members. Thank you, thank you, thank you. All the artwork, the dedication, making sure that things work the way we want it to work. So please help me to appreciate my amazing team again. Thank you, guys. We are just very grateful to multiple departments in the university, that supported us: KTSU, Office of the Provost, Marketing, all the different units across Texas Southern University, to Consolation X, our audio team, our AV technician. Thank you guys. We are grateful to you. And to all our volunteers, my own children included, several volunteers in the front, in the lobby, making sure lunch is ready and prepared. We are just very grateful. We couldn't do this alone without you guys. And of course, to our sponsors, right? Our NIH and NCI will not pay for water. They won't pay for the food, but we are grateful for these sponsors who continue to ensure that we can provide these services. And to our partners, the church here at Progressive New Hope Church, Harris County Public Health, the mobile unit. Thank you, Colondria, and your team for your continued support. Aetna, they are all out there. Please visit with them in the lobby and also in the parking lot to receive all these incredible services. These are all, this is the map of the layout for those that are outside in the parking lot, as well as to this side. This is where you can interact with vendors and also lunch. So now I have the most challenging task of the day. And this task is to invite up my husband, my one and only husband, as he closes us out in prayers this afternoon. Andrew Wema is a gifted musician, and his passion for worship and music is what sets him apart. With his background as a musician and keyboardist at his local church, he brings a unique perspective and expertise to the world of worship music. And by the way, that's how we met. We met in the church. He was supposed to be playing the piano. I came to the choir. And it's been 13 years and forever. In addition to his musical gifts, he is an accomplished entrepreneur and a Maxwell Leadership Certified coach, trainer, and speaker. He is a Building Dads and Manhood University graduate and ambassador from Powerhouse Church. His broad range of skills and experience makes him well equipped to lead and inspire others in their spiritual journey. He is also an author of multiple books, one of which is How to Build Effective Worship Team. Andrew and his wife, which happens to be me, Veronica. We are blessed by 4 wonderful children. 2 of them are over there, and we reside in Katy, Texas. Please join me in bringing up my wonderful husband, Andrew. Thank you so much, babe. Love you.
She told me I should not pray everlasting prayers because we're about to go eat. So let's pray. Father, we thank you for this session. We thank you for everyone that came, all the panelists, the doctors, the healthcare providers, and even for this church for opening the doors for us. Lord, we return all the glory. According to your word, James 1:22, we shall be doers of your word and not just hearers. So as we leave this place, we ask for the grace to take to action everything we've learned. And at the end, we'll look up to you because you are our healer. We thank you, we exalt you, we give you praise. In Jesus' name we have prayed. Amen.